Good morning, everybody, and welcome to the Rural Health and Care Wales Conference for 2024, which is a 3-day event this year and is known as a marathon, not a sprint, amongst the team. So welcome. And I'm just going to go through some housekeeping, if that's okay, just quickly for everybody, particularly those in the room. Those at home, I'm assuming you're making your own arrangements for fire escapes and toilets, etc. So if I start us off in here with fire escapes are well noted in various parts of the room, so there's no reason to miss those, and there's a gathering point outside. Toilets are behind me. If anybody wishes to use those, please use them. Do not worry about us speaking or anything of that nature. They are there, and you can use them whenever necessary. Just to be really clear, the conference is being broadcast internationally across a number of countries on Teams, so that's one thing. The other thing is that we are recording as well, which means that that will then be available on YouTube following on after the conference going forward. Pictures will be taken during the event for various reasons. If there's anybody who wishes not to have photographs taken in any way, shape or form, can they let the team know by the door so that we can avoid that? That would be really useful. Thank you. So, as always, up front, this is a technically difficult exercise to pull off. We've got presentations being done in the room live. We've got presentations online live. We've got recorded presentations being done as well. So as we feed those into the system, there may be some technical hitches. So I'm going to apologise up front if I have to sing at any point or fill any gaps. So I do apologise for that, but it will be, I'm told, running smoothly. It would be really good if we could make sure our phones are on silent, because that really helps us in terms of making sure that we can concentrate on what we're doing. And could we also make sure online, please, that microphones and video cameras are off? That would be really useful. So anybody joining us online, if we could, during the presentations, make sure that video cameras and microphones are off, that would be really useful. In terms of online, if you have a question at the end of presentation, you can put them into the chat or the Q&A section, and you can also raise your hand, and one of the team will spot that and will raise that question so that we can make sure that that gets answered. Obviously, in the room, we can do a traditional thing about raising our hand up and saying we'd like to ask a question, which is good and still works, by the way, so that would be really good. And we'll have time for, at the end of every presentation, for some questions. When you ask a question, if possible, if you could introduce yourself, that would be really useful so that we know who's who and who's partaking in that. That'd be really good. For most of the day, we will be in this room, but obviously the breakout sessions will be in the International Pavilion, which is just over the drive there. And online, you will be able to select, you'll be given the options to select as we go through this morning, if that's okay. In the International Pavilion, we are on the ground floor and we're upstairs, depending on which option you go for. There'll be plenty of people to help and guide you with that, if that's okay. I always have to remind everybody that there is a poster display here, and they are fantastic posters, and it's a really good number that we've had this year. Anna and I had the pleasure of going through them and trying to work out what we were going to do with the numbers that we had, and it was a significant task that took us quite a long time, I must say. So they're available. There is a scoring sheet available that we would be really happy for you to fill out and to submit so that we can then come to a conclusion with regard to the prizes for that at the end of the session. The 3 highest scoring posters will get an award. So just to be really clear on that. And online, they will become available to you as well as we go through the process. In terms of translation, those joining online should have been given an option coming into today, and should be able to pick the translation up from there. Those in the room, there are headsets available if we need them, and if anybody needs them, they are there, and please pick them up. My gut feel is that we will need some this afternoon, definitely, from looking at the agenda. So that will be something we'll need to do for this afternoon. Okay. It's a full day, but it's not as full as we have had in previous years. Squeezing this into 2 days has always been a bit of a difficult task for us, and hasn't given us much time to talk to each other. And so talking to each other is just as important as everything else that goes on today. So there's some space in here now, and some space at the end for people to actually have conversations and to interact and talk to each other. So that's why we've built that into the programme, just so everybody's aware. Okay, so I'm going to now ask Anna to play a video from Jerry Miles, MS, the Cabinet Secretary for Health and Social Care, from the Cynhadledd, who is going to open our conference for us today. Anna, over to you.
Bore da, mae'n anrhydedd cael agor Cynhadledd Iechyd a Gofal Gwledig 2024 yn fy rôl newydd fel ysgrifennydd y Cabinet dros Iechyd a Gofal Cymdeithasol. I'm honoured to be opening the Rural Health and Care Conference this year in my new role as Cabinet Secretary for Health and Social Care. This is a really exciting time to be exploring the innovative and pioneering ways Wales is leading in the health and care sector, which of course includes a strong focus on the challenge of delivering excellent health and care in our many rural communities. I'd like to start by congratulating the Powys Teaching Health Board, the Betsy Cynhadledd University Health Board, and the Hywel Dda University Health Board for their collaborative approach in enabling this platform for guests, both national and international, to come together to discuss developments in the delivery of rural healthcare. In the Welsh Government, we know that there are still inequalities in access to health and care, but we want everyone to be able to access quality NHS treatment and excellent social care, no matter where they live. One theme the conference will focus on this year is the development of integrated health and care services in rural areas, including advancements in cross-sector, multi-agency and multidisciplinary working. When we set out our vision in A Healthier Wales, our long-term plan for health and social care, we envisaged a system founding on place-based care, care closer to home, and multi-professional working. We see these principles as the main element of a whole system approach to drive radical change and improvement in our health and care systems. One example of brilliant cross-sector working is the new state-of-the-art audiology vehicle in Betsy Cynhadledd University Health Board, which recently embarked on its maiden voyage, providing high-quality NHS care to rural communities across North Wales. It's the first of its kind in Wales, and the project, which is completely charity-funded, began hitting the road at the beginning of September. It's tremendous to see the Health Board collaborating with the third sector in this way, and I'm excited to see what this project achieves in the future. A Healthier Wales envisages citizens being able to be cared for and, where possible, treated away from a health setting, allowing a greater emphasis on self-care and on remote management. Effective use of digital and data is therefore essential to our approach to improve the delivery of services in rural areas. Last year, we celebrated the establishment of the AI Commission for Health and Social Care as a key step forward in this arena. And we have already begun to see health boards in Wales use AI to support clinicians in several diagnostic settings across Wales. For example, in Betsy Cynhadledd, with the innovative use of AI in pathology for the diagnosis of prostate and breast cancer. Another exciting development in the advances of technology is the rollout of the Digital Medicines Programme, which was established in 2022. The programme aims to make prescribing, dispensing and administration of medicines easier, safer, more efficient and effective for both patients and for prescribers. Communities in North Wales were among some of the first to experience the benefits of the electronic prescription service, and as of the beginning of October this year, the service is live in 13 GP practices and 51 community pharmacies, with rollout continuing rapidly. When Professor Longley wrote his report back in 2014, I doubt there were many amongst us who'd heard of the potential of social prescribing, which can unlock resources and connect people to their local community assets to better manage their own health and well-being. In 2024, we've seen this area expand exponentially, and our National Framework for Social Prescribing, launched at the end of last year, aims to support local action to mainstream social prescribing across Wales. One exciting element in this area is green prescribing, which is a form of social prescribing that focuses on nature-based activity, and it has the potential to be utilised widely in our beautiful nature-filled rural areas. Delivering rural healthcare comes with a myriad of challenges, and none more so than the recruitment and retention of health and social care professionals in rural areas. I was delighted to officially launch with the First Minister the North Wales Medical School at the beginning of October, with 80 students commencing their studies in medicine. The school will enable us to train more medical students here in Wales and ensure that we distribute both training opportunities and the provision of well-qualified doctors in all parts of Wales. In terms of retention, since 2017, we've provided financial incentives to attract GP trainees to specialist training schemes in North, Mid and West Wales, areas that are historically hard to recruit to. The Train, Work, Live marketing campaign has worked with partners to deliver a significant increase in the take-up of GP training places over recent years. A total of 199 new GP trainees were recruited to training schemes across Wales in 2023. Our commitment to paying the real living wage to our social care workforce also continues to have a significant impact. All local authorities also have access to the Social Care Wales Workforce Development Programme, which provides training opportunities to social care workers in their communities, both in the voluntary and independent sectors. We also support those members of our care workforce who are not paid to carry out their services. Carers Wales estimates there could be up to 450,000 unpaid carers in Wales, which is around 1 in 6 of the population. Since 2022, the Welsh Government has allocated £42 million to deliver support to unpaid carers, and £1 million has been paid again this year to local health boards to deliver activity focusing on supporting unpaid carers when the person they care for is admitted to or discharged from hospital. If I can conclude by returning to our vision in a healthier Wales for a system based on place-based care, care closer to home and multi-professional working, we can now see we have many of the tools in place to enable this way of working. Cluster working is the way we see this being delivered, with collaboration between the people who deliver the wealth of local services in our communities at the very centre. Working in this way shapes our understanding of the needs of the population and provides access to the right care from the right professional, thereby improving outcomes for people. Cluster working draws on alternative solutions to minimise over-medicalisation and increases and optimises skills and capacity in the community to support self-management. To meet these aims, we established the Accelerated Cluster Development Programme to clarify and distinguish the planning and delivery functions of clusters. I know that clusters and pan-cluster planning across Powys, North Wales and Hywel Dda have the solutions to meeting the health and well-being needs of their communities. We must continue to empower frontline services to innovate and embed successful solutions and make a virtue of the communities which make up our most rural parts of Wales. Diolch yn fawr.
Thank you for that. In terms of that introduction, some quite interesting things there, aren't there, about words like empowering and enabling cluster development and cluster planning. And so for me, to enable that, we've got some radical rethinking to do on where funding channels go and how funding is dealt with in terms of working through the system. The days of the big shiny hospitals full of people being sucked into them for everything are going to have to dwindle, aren't they? Because we're going to have some, if we're going to get care closer to home, we're going to get care into the community, and we're going to get care at home. The money from the big shiny hospitals is going to have to be rethought through and reallocated out into community care. There's no major pot of additional money going to come flying into the system to enable that to happen. So we're going to have to see a shift of resource across the boundary from that well concreted building into a more fluid community and local setting, really. And that's going to be a real challenge. That's where the real challenges come. And we're seeing some of that happening with regard to clusters and regional working, etc., regional partnership boards, those sort of things. But they're not really bringing out the best in terms of innovation and improvement. People are doing some of these things on these posters, some of the things we're going to hear presentations on over the next few days are because people have an interest. People have the energy to push things and move things forward and to try something new. And one of the things I think we've got to be really, really sure of is that we have to enable those individuals with that imagination and that creativity and that innovative thinking to do what they're doing and to drive things forward and move things. We've got to support that, because if we don't, it will just become a more of doing the same thing that we've always done, and an inability to be able to deliver what we said in the Wales strategy, which is care close to home, driven by those people in the localities that make a difference. And for me, that is really important. If we're going to do this properly, then funding streams are going to have to follow. Because we see a lot of the projects that I'm sure people in this room are doing all the time come to an end, or funding comes to an end, and we don't see it then move into core funding into the system that we would like it to move into. So for me, the funding stream and the different approaches to how we fund things is vital if we're going to continue with the innovation that we've got in the system. So wanting to grow that innovation and fund it is really important. Regional partnership boards play a part in that. Why do regional partnership boards exist? Why are they around the table? They're there because there's a pot of money in the middle of it, personal opinion. They're not there because they feel that they can work in a supportive way, particularly in the areas that we're talking about and focusing in on in Mid Wales. I'm being very controversial on that, but it is, in my opinion, a very opportunistic funding related gathering, not a needs assessment, needs addressing delivery that we need in the future. So in terms of us moving forward then now, have I filled enough time? I've got myself into enough trouble. So in terms of the reason I'm saying that is because we have some overseas presentations happening which won't be out of sync, because if they are, we'll end up going into the middle of the night in some places. So just to be clear. So we're going to now move on to the plenary number 1, which Anna is going to do the introductions for, because Anna's been playing a part in that. So Anna, I'm going to hand over to you now, and you're going to film for a bit. Thank you.
Good morning. I'm just going to provide an introduction to a piece of work that we're doing that has expanded really, and I can see the person who probably instigated it all sitting to my left, which is Dr. Sue Fish, who was sitting on our stakeholder group. And at the time, think it was going back probably to the beginning of the year, we were looking at the dire need for a review of GP practices across the region. And this isn't a regional problem, this is an international problem. There just aren't enough GPs to meet the needs of individuals. In Wales, I know in England they were cited that there are 6,000 GPs short. In Wales, over the last 10 years, the GP numbers have dropped by 18%. And when you take that as a full-time equivalent basis, that's over 21, nearly 22%. And more worrying than that, a BMA study conducted last year demonstrated that 80% of GPs are concerned that the services they are providing aren't fit for purpose, with nearly 27% of all GPs considering leaving. So you can see the situation is dire not just in the UK, but across the world. I was involved in some peer review work in France earlier this year when they had a huge GP crisis in the Loire Valley, but when you actually looked at their stats, they had more than double the amount of GPs per patient per head of the population that we do have here in Wales. So Sue raised the fact that, you know, GP practices, and the ministers talked about moving towards an integrated care model. So we were asked, Rural Health and Care Wales were asked to conduct a piece of research looking at different models of delivering primary care services in rural areas, and to come up with an action plan for the group to take forward then to the Mid Wales Joint Committee. I'm just going to put the presentation up. Sorry, bear with me a second. You all see that. This was the task we were given. So when we develop an annual work programme for Rural Health and Care Wales, we have to align it to the strategic priorities of the Mid Wales Joint Committee. And their second home was to develop this care closer to home, to create a substantial health and social care system for the population of Mid Wales, which has greater focus on care closer to home. And primary care GP practices form a core part of that. So the question we were given was to conduct research into the GP provision across Mid Wales, exploring best practices, examples of alternative models of delivering primary care interventions in rural areas. And we were aiming to complete that by July this year. But as with everything, we've had significant delays, but that's because the work has suddenly expanded. So what we did originally, we've been working with the Think network in Aberystwyth University, which is a pan-Wales organisation. It's the Transport and Health Integrated Research Network. And they offered us a secondment opportunity, and that's with Dr. Angela Curl in New Zealand, who is going to do a review of travel distance to the nearest GP provision in Mid Wales. And building on that, we'd also spoken to Professor Ronan Lyons of Sale Data, and you're going to hear more about that in a minute, who was very interested in working with us on a former project and using this kind of analysis as a basis for a bigger project over the longer term. And Sale Data, if you don't know, Rowena's going to explain that, is data that GPs willingly collate nationally that then can be analysed and statistically reported, all anonymised, I will add. So the form of our research, like with most things in Mid Wales, transport and logistics are a huge part of the problem. So the first part was to look at the logistical issues, distance travelled and accessibilities of GPs. And this is where we're between stage 1 and stage 2, actually. And then the second part was to look at health profiling of the people of Mid Wales in terms of what was recorded at a primary care level. So I'm going to hand you over now to Rowena. To Angela first, who should be online, and I'm going to have to sit down to do this. Angela's joined us from New Zealand, and she has done an analysis of publicly available data in terms of distance travel to GP, but it's on the basis of the assumption that people go to the nearest GP. But as you know, that isn't always the case, with often people choosing to go to the GPs that they've always grown up with, or the GP in the location where they might work. And then building on from that, the SAIL team, and we've got Rodri in the room and Rowena who's going to talk later, have looked at the data then, the actual data in terms of postcode registrations of patients, and they've linked that to some health statistics, which we can explore in a minute. So, excuse me, I'm going to call Angela up on screen now to give her part of the presentation. I don't think we can hear you, Angela.
Can you hear me now?
Yes,
Okay. And can you see my slides?
we can. Yeah.
Okay, great. Thank you. Okay, Boida, kia ora, everybody from New Zealand. And thank you for the interjection, Anna. I thought I would just start with a little bit of a background to why I'm here talking about this all the way across the other side of the world in the middle of the night. So I am in New Zealand. I'm a lecturer in public health with a background in transport and health. Although I'm here in New Zealand now, hopefully you can hear that where I'm from is just this small town over the border, not too far away from Wales at all. That small town being Birmingham, which is so my experience has been mainly urban until coming to New Zealand, and I've become much more aware of rural health issues and access to care. So this is a map of the South Island where I am showing the rural, the darker the green areas are, the more rural they are, and the issues that I've already been hearing about this morning in terms of access to care and access to primary care are a particular issue across a lot of the South Island in particular as well. So as Anna was saying, these are international issues. And Anna's already mentioned THINK, the Transport and Health Integrated Network, which I'm a member of and have worked closely with Charles from Aberystwyth University before. So the reason I responded to this opportunity was because the reason that I do research is to have impact, to make a difference, but sometimes it can feel quite far away from that. And I saw this as an opportunity to work together with Anna and Rural Healthcare Wales to actually look at something that was a real practical issue at the moment and to get involved in that. And so I was really pleased to be able to do this work, despite being all the way over here. Okay, so I'll briefly go over context, but I don't think that this will be particularly new to everybody in the room. As we know, poor access to primary care can lead to missed appointments or appointments not being made in the first place. Missing out on primary care leads to later diagnosis and treatment, so overall poorer outcomes. And distance and lack of transport can act as barriers to accessing care and can lead to that unmet need. As we know, accessibility is a particular problem, especially in rural areas where the distances that people have to travel are typically longer, and public transport services are limited, and the healthcare services face a number of issues, including staffing issues. There's some previous work in England, although it's quite old now, which found that while across the whole country, over 84% of the population lived within 1.6 kilometres, so they used that as a distance that was walkable of a GP, that in rural parts of England that reduced to 19.4% of the population, so huge disparities there in terms of that threshold of 1.6 kilometres. And that this is becoming an increasingly important issue for us to look at alongside demographic change and an ageing population who may not be able to rely on car-based travel. It's important to consider how healthcare services in rural areas and how we can evolve to meet those challenges. So what we did in this population-based analysis was to focus on the region, the Mid-Wales, rural Mid-Wales region. I'll show you the area that I focused on in the next slide, but the area had a population of 184,000, covering about 82,000 households, and included 34 GPs. That includes main sites and branch sites, and did a shortest path road network calculation to the nearest GP from postcode centroids. So calculated how far people would have to travel to get to their nearest GP, and then also looked at the number of GPs that people would have available within different thresholds up to 20 kilometres. So that starts to look a little bit at what options are available, not just the nearest one, because as we know, there may be multiple reasons why people don't use their nearest practice. And then I linked that in with population data at a lower super output area level allocated to the postcodes within each super output area to create some population-based estimates of access. So looking at overall what proportion of the population have access to GPs, but also breaking that down within different demographic groups, which I'll show you in a moment. So this map is showing distance-based thresholds from those GP practices. So the green dots are the GP sites. The black outline is the region we looked at. And those, the colours are increasing in distance. Sorry, the legend has not quite been tidied up like I thought I had done, but I used 1,000 is 1,000 metres, so 1 kilometre, 2 kilometres, 5 kilometres, 10 kilometres and 20 kilometres. So you won't see the buffers of 1 and 2 kilometres on this map because we're too zoomed out. But I'm hoping to provide this available as a resource that can be zoomed in and out of for people who want to come back to it at a later date. But you can see there that the areas that are not coloured are more than 20 kilometres from the nearest GP, and that dark blue is those that are between 10 and 20 kilometres. There's a green in between, which is 5 to 10, and then the lighter blue that you can see is up to 5 kilometres from the GP. So then linking that in with population data, this graph is showing the proportion of the population who has a GP within each of those distance thresholds across the bottom, and it's got breakdowns for different segments of the population. So the main thing to note from here is that the majority, it's around 99.8% of the population across all those groups have a GP within 20 kilometres, but there are substantial differences when we look at shorter distance thresholds. So, for example, if we take 1 kilometre, then under 30% of the population in that rural Mid Wales area have a GP within a kilometre. And the main discrepancies or the main differences amongst different groups of the population that we can see here are higher proportions of the population of those who have no car or van in the household, or those that are non-white British, so ethnic minority groups, are more likely to have a GP closer to home, which makes sense given that they're probably likely to live in the more densely populated areas if you don't have a vehicle available, and that and the same with ethnic minority populations, less likely to live in the most rural areas. So higher proportions of them have a GP within 1, 2 or 5 kilometres than compared to other population groups in that area. And then this is just taking just population and households rather than all of those groups for a comparison of the Mid Wales area with all of Wales. So on the left-hand side, it's the calculations for all Wales, and on the right-hand side for the rural Mid Wales area. So although about 40% of the population in all of Wales have a GP within a kilometre, that's below 30% within the rural Mid Wales area. So you can see that in the rural area it's lower than all Wales, which also includes that area. So it is all of Wales, not just the rest of Wales. And then looking at the average number of GPs available within each of those thresholds. And again, this is comparing Mid Wales to all of Wales. We can see that although, as I said before, most people do have a GP within 20 kilometres, there's very few options in the rural Mid Wales area. So it's less than 4, on average, less than 4 within a 20 kilometres. Whereas for all of Wales, that's above 9. And in reality, it's actually probably greater because I had to cut off the analysis after counting 10 GPs within those thresholds just for computational reasons. And so you can see across all those thresholds, the population in Mid Wales has far fewer number of GPs within the threshold than all of Wales. I then used some secondary data that looked at public transport access to GPs. This is calculations that have been done for the whole of Great Britain. So it's quite limited in terms of the unit of analysis. They've calculated it at lower super output area, which in rural areas is much larger areas, and so it's aggregating and making an assumption that the same access exists across the whole super output area, which is not the reality. So, but it's just to give an idea of what that nationally available data looks like. And it would be possible to do this at a smaller spatial area too. So the darker purple there are the up to 120 minutes. So it looks at journey time rather than distances when using public transport. Again, the areas that are not coloured have no public transport available to GPs, according to this data. So I think there are some issues with it. I just wanted to share it to give an idea of what it looked like in terms of public transport access. So to summarise the results, 29% of the population in rural Mid Wales has a GP within a kilometre compared to 40% across all of Wales. As I said, those without a car or a van or non-white British tend to live closer to GPs, and almost all of the population do have one GP within 20 kilometres, quite a large distance. And there were not many options. So on average, there were 3.8 GPs within 20 kilometres in rural Mid Wales compared to more than 9 in all of Wales. And there's limited public transport and limited data on public transport, and even harder to model or to look at what community transport might offer, which I know is an important source of transport, particularly in rural areas. And so actually starting to understand what's available and what that means in terms of people's access is also important, but not something that we're able to look at the moment. So there's lots of, this kind of sets the basis for a very baseline analysis of how far people are living from GPs, but this sets the groundwork for a lot of other potential work that could be done. As we know, people often go further than the nearest GP, and there's been some work in New Zealand looking at what factors explain why people don't use their nearest GP and trying to understand what that means in terms of provision of care. So linking up with the SAIL data, that would be potentially a possibility. Looking at how much of a role distance plays in missed appointments, and also starting to look at the catchment areas of practices and patient registered addresses, looking at the coverage relative to the population that relies on that. And with this kind of accessibility spatial mapping, we could model the impact of closing a particular practice or moving it or providing a new practice and what that would do in terms of access at the population level. So some of the different models of delivery that are being discussed could be modelled at a population level. So thank you. That's all I have to say. Happy to answer any questions.
Good morning, everyone. It's really nice to be here in my what is actually my home community. I grew up just a few miles down the road from here, so it's a pleasure to be speaking to you this morning. As Anna mentioned, I'm Rowena Bailey. I'm a statistician and a health data science researcher based at Swansea University, and following on from the introduction to this study and the talk that Angela's just given, I'm going to be speaking to you about some work that we've done using the SAIL data bank to look at the distances that are travelled between the place of home residence and your registered GP, specifically focusing on people living within rural Mid Wales. So I'm speaking on behalf of a team, my colleagues, Rodri Johnson, who's in the room with us today, and Jane Lyons, Richard Fry, and Ronan Lyons, and we're all based at Swansea University. We're funded collectively by Health Data Research UK, Administrative Data Research UK, and we work as part of the Environmental and Health Research Centre, which is headed up by Richard Fry and Lucy Griffiths. And we are probably better known for working within population data science at Swansea University, which is home of the SAIL data bank. And as Anna mentioned, we were given this challenge to see if we could leverage the SAIL data bank to evaluate those distances that are travelled between place of residence and your registered GP. So for those of you that don't know, I will just very briefly give you an overview of the SAIL data bank and more specifically the technology that underpins it, which enables us to access billions of records for the entire resident population of Wales. It brings together healthcare records from primary care, secondary care, from emergency departments, from outpatient appointments, cancer registry, as well as increasing amount of administrative data, looking at social care, provision, police data, Department of Work and Pensions, census, the list grows. But all of that is facilitated by a technological infrastructure that really has privacy by design at its heart. And without going into the detail, it essentially means that researchers such as Roger and myself are able to access all of this data without ever seeing any patient identifiable data. So the data we use is all completely anonymised, enabling us to carry out research and protecting the privacy of individual patients' information. So as well as all of the electronic health data that we have available to us, we also have a GIS secure research platform, and this enables us to include, as well as the health records, but increasing amount of environmental data such as ambient noise, air pollution, walkability, green spaces, access to unhealthy food environments, and proximity to provision of services. We also have data on the type of houses that people live in, whether it's a detached house or the quality of that housing, and that's all facilitated by a residential linkage spine, which contains approximately 1.4 million households across the whole of Wales. That information is then brought into SAIL, again linked anonymously, so we never know the individual locations of people's addresses. We get a unique residential identifier, and that is what's enabled us to do analysis at a household level. And that is, again, a technological process which I won't go into too much detail on, but it is facilitated by UPRN numbers, which are maintained by local authorities. And that's been used in SAIL as the address identifier since about 2012, which we can then link to individuals based on their registered address from their health records. And that is what we've utilised for this study in order to link together the place of residence, where someone is registered as their home address, to the registered GP. So to do that, we extracted the locations of all GPs across Wales and created a geospatial data set, which included 545 GP surgeries across Wales and the 1.4 million households. They were then combined using the GIS infrastructure to calculate the road network distances between every house and every GP across the whole of Wales, which was over some 760 million calculations. That data set was then encrypted and brought into SAIL so that we could analyse these distances. Once we had linked all that data together, we had over 3 million individuals in our data set, with living in about 1.2 million properties, registered to around 420 GPs. Now, in SAIL, because the data that is provided to us is an opt-in service by GPs, not every GP in Wales provides its data to sale. We're always hoping every year that we'll get more and more and eventually have complete national coverage. But to date, we're not quite there with GPs. So once we had included only those that provided data to sale, and we included GPs that were either part of the Mid Wales study group or those that were in urban locations, we had about 1.9 million persons in about 810,000 properties. We further then had to exclude GP persons that were registered to GPs where that GP practice was part of a multi-site or a hub. So this was an interesting challenge for us in Sale. We'd never used the data in this way before, but what became a challenge is that where the data is collected nationally, individuals are registered to the main branch site of a hub. So when we receive that data, we're not actually able to tell if you're visiting your local GP or if you're visiting the main headquarters or the main branch site for a particular hub. So we removed those in order not to skew our results, and that left us with 15 GP practices in the Mid Wales study group, and then we compared those to people registered to 136 other urban located GPs in the rest of Wales. So as I mentioned, we have all this health data and demographic data. So we produced profiles of the demographics of individuals registered to the GPs. And I'm guessing that a lot of this is not particularly surprising when we found that people registered to the Mid Wales GP group were generally older, were more likely to live in the middle deprivation quintiles. They were more likely to also live in rural areas, and they were more likely to live alone compared to people registered to urban located GPs across the rest of Wales. But what we were really interested to know and to support the project that Hannah described is to find out what the differences are in the distances that are travelled between people living in Mid Wales and the other urban located GPs. So on this chart here, we can see at the very top in grey is the distribution of distances that people travel to urban GPs, and in blue is the distances travelled for the whole of the Mid Wales group. And then followed by that underneath, we can see the distributions for each of the individual GP practices, which you'll see we've anonymised here using the alpha characters, so we don't actually know which GPs they represent. We can see from this data immediately that there's a huge spread of distances travelled by people in registered to rural Mid Wales GPs compared to the rest of Wales. And the summary of 50% of individuals live between 1.5 and 9.7 kilometres from their GP in rural Mid Wales, compared to 50% living between 1 and 2.9 kilometres for urban located GPs. So when we looked at those differences then, on average, the distance travelled in rural Mid Wales is 6.35 kilometres, and that's compared to 2.25 kilometres for urban located GP patients, difference of around 4 kilometres, and that was statistically significant when we tested that. As Angela mentioned as well, we were also interested to understand the differences between where people's nearest GP was, not just the GP that they were actually registered to. And when we looked at those differences in Mid Wales, the Mid Wales GP patient population had a mean distance of just over 5 kilometres, and that was compared to about 1.5 kilometres for the urban located GP population, difference of about 3.6 kilometres. And that was also statistically significant. So we were really interested to try and understand actually what proportion of patients were registered to their nearest GP. And we can see that across the rural GP practices, indicated by the dotted line, was the average, which is about 63% for that Mid Wales patient group. And that's compared to around 45% for people registered to their urban to an urban GP in the rest of Wales. So we also produced some health profiles, really trying to leverage all of the data that we have in Sale, which again, I'm happy to talk to you about this afterwards, but we have lots and lots of data available to us from primary care, secondary care, emergency departments, and that enabled us to produce health profiles for each of the GP practices. So they're represented in the columns here, and looking in the rows at individual health profiles. So the top one being the profile of frailty, the percentage of people in each GP practice with a frailty status of mild, moderate or severely frail. That data is created using 10 years of GP data looking across 36 clinical domains to understand and assign a measure of how frail each person in their registered patient case mix is. Similarly, then we have information on the number of multi-morbid conditions that a patient might be living with. So we include over 47 disease classifications in order for us to identify how many people in a patient population are living with 2 or more comorbid conditions. And then we also have a number of indicators that are part of a desirable health indicator, and it looks at things like how many hospital admissions patients have had, emergency department attendances, prescribed medications for things like infections, pain relief, or mental health. And generally, when we compare the Mid Wales population group to the rest of the urban located GPs, we find that there's higher proportions of persons that are categorised as frail and multi-morbid, and there's lower proportions of persons that are being prescribed medications for pain relief, infections or mental health conditions. So that's a bit of a whistle-stop tour through what we've done to date. We'd really like to build on this work and continuing to work with Anna and Angela and the team to understand really what the differences are between the place that someone is actually registered to their GP and their nearest GP. As Angela mentioned, understanding some of the reasons why that is might be really useful, and to understand the differences in the impact of distance on individuals' health outcomes. And as well as looking at distances to GPs, we could further expand this work to look at distances to other healthcare provisions. So access to hospitals, A&E departments and dental services would also be an area of interest. Not least to me personally in my current condition, because I'm really well aware of how living in a rural community impacts the distances required for me to travel to make antenatal appointments, etc., where I'm travelling large distances, often at personal cost and time to myself. And I think there's a huge area of research around understanding distance and provision of healthcare. Thank you very much.
Thank you for that fascinating stuff, and it would be really interesting to see how that changes over a longer period of time as well. It'd be quite interesting to see whether some of the things we're doing are actually making a difference. We've got a few minutes for questions, I think, Anna. We've got about 5 minutes, so if anybody has any questions, I'd be willing to field those for anybody. Yep. Ellen, do you want to, have we got a microphone? It's about to run your way, I think. So.
Yn ofyn i ynglyn â'r sleidol am dyn oedd yn diddorol. Sleid o lan dyn oedd yn mynd i gofod yn gwirionedd yn dweud yna ydyn yn dod yn cyfan sy'n gilydd. Ac am hwn i oedd yn y cwestiynau ynglyn â nesaf chi gyffwrdd ar nifer o weithiau pobl yn mynd i'r ysbyty heb i gynllunio yn mynd i heb i gynllunio. Ac am hwn i yn y cwestiynau, a oedd yna unrhyw gysylltiad rhwng pa mor ddech oedd rhywun a pa mor aml y pobl yn sori gwneud. Sefyllfa pobl yn torri lawr ac angen i gael pobl yn ysbyty.
Thank you. Dim siarad Cymraeg. Apologies. But absolutely, it's a really interesting question trying to understand whether attendances and unnecessary attendances at A&E or admissions to hospital are influenced by the distance that people have to travel. It's not something we've taken into account at the moment. We've just looked at the health profiles for individual patients. But what we'd really like to do is bring that together and actually see how the distance and the proximity to those services affects health utilisation. It's a pretty well-known phenomena with things like A&E attendances, that the closer someone lives to a hospital, the more likely they are to present at A&E. But we're also increasingly aware that things like distance to hospital might increase things like length of stay in a hospital, and because of the challenges of being able to be discharged and then provide the continuity of care back in the community. So yeah, it's a really interesting area. We haven't done that yet, but we're really interested in looking into that in the future.
Thank you for that, Rowena. Any other questions? Anything online? I'm assuming somebody's watching. No questions online. Okay, Sue.
The lack of choice they've got about different GPs. We're being faced across the UK and in Wales with GP practices closing. Those that aren't closing are being taken over by corporate companies which are delivering other models of general practice. This hasn't happened in Midwest yet, but it's only time. So I wondered what the next steps were going to be for Health and Care Wales and looking at what the general practice audit needs to look like. Or otherwise we will be looking at these figures in 5 years' time, saying that people are having to travel further to visit their GP and the services that are available from them have decreased.
Thanks for that, Sue. And I think you know the point you make is really well made, and I think it potentially is a kind of time bomb, really, isn't it, in terms of waiting to happen, in terms of when you look at be interesting to pan in the age demographics of those GPs as well, really, in terms of where they are in terms of their career and their retirement plans, etc. Because I think there's a real big issue about to hit us, and I would suggest it's within 5 years that we'll have a real major issue there. It would be interesting to kind of build that into the work that we're doing, and we're looking to kind of extend that work anyway going forward. And I think it will be really good to kind of play that into where we're at. At least then we will have a position where we won't be knowingly walking into that position, and we won't be kind of blindly doing it as we are at the moment. So I think that's a really good point. Anna, I don't know whether you wanted to add to that.
The only thing I was going to add is that part of this work as well has been looking at best practice examples internationally, and I think you're more than aware, so that multi-agency and multidisciplinary and integrated care type models are definitely the way forward, and using other disciplines, healthcare professionals and social care professionals and pharmacists and paramedics to build a team around the GP. Also the mainframing, I suppose, the social prescribing, re-prescribing for social ailments. These are the models that are succeeding or have been succeeded. I think there's some up in North Wales in Anglesey which have been cited as a great practice, whereby there was only one GP to cover a number of patients, a situation that was deemed to be impossible. But by building a team, a different type of team around the GP, and that has alleviated some of the problems. So we are looking at different models from across, and we will come out, part of the research is obviously to come out with an action plan of, recommendations for Mid Wales. We do face very similar problems to what our experience answer, but we also face some problems that are unique to the region in terms of accessibility, lack of public transport, an elderly population with complex health needs and a growing elderly population. So yeah, it will be quite a comprehensive report at the end. I think something that maybe Rowena didn't add is that we're hoping that this will provide, once we've done a health profiling across the region, which covers the 3 health boards, that this will provide a baseline for us to measure the impact of any changes over, say, a longitudinal period of maybe 5 years, to look back to say whether did that have, a positive impact. And that's will be quite unique, I think. I can say that, not Rowena's nodding, 2 ways, and that'll be quite powerful data to have.
Thank you, Anna. Thanks for that. And then I'm afraid we're going to have to move on at this point because we've got the 11 o'clock deadline to hit, and I think I'm behind on it slightly. So I'm going to move us on if that's okay. So we're going to move on now to our second plenary, which is Dr. Maring from the Netherlands, who I hope is online and with us. I've got the nod, so that's good. So we're going to be sort of looking at redesigning Dutch healthcare. So Dr. Maring, I'm going to hand over to you if that's okay.
Yes, thank you for inviting me to give a talk on our connected care program from the Netherlands. Please confirm, do you hear me? Am I?
Yes.
Yes, okay,
Yeah.
that's great, that's great. And now I'm going to share my screen, and I hope you will see my PowerPoint now, and not yourself. Where's my PowerPoint? It's gone. It ran just a few, I had it steady on my screen, but no, here it is. Do you see this?
Yes.
Yeah.
Okay, thank you. Okay. So I'm a hospital pharmacist and a clinical pharmacologist, and also director of the Connected Care Center of the Isla Hospital. It's a hospital that's in the Netherlands, in a little northeast in the Netherlands, and this is where we are located, the city of Zwolle, and we're the largest non-academic top clinical hospital in the Netherlands, but in a very around Zwolle there is a big rural area, and about 700,000 inhabitants have Isla as their main hospital for care. And we have several locations around the city of Zwolle. We have a little more focused clinic in the Meppel location, which you can see on the right upper side, and some locations in Kampen and Heerde, which are small cities around Zwolle. But we're a very big hospital, level 1 trauma center, cardiothoracic surgery, neurosurgery, neonatal ICU available, and a big oncology center. So people from around the area all come to Zwolle to get high care, and also for standard care. But if there is a big problem, we can also help them. Because the next academic hospital is 1 hour to the north or 1 hour to the south in Groningen and in Utrecht. Well, of course, it's connected care is about for, I think 50, maybe 70% is also about getting connected with your patients by digital helps. And the world of today is very digital and connected because we order all our groceries, and at least in the Netherlands, we get our groceries online, and they bring it to your home. The banks are all digital, and so on and so on. If you want to order books, you go to the bol.com in the Netherlands, and you can order all kinds. And we also all know Amazon, and so on and so on. But well, this is what was 30, 40 years ago. When you got to your bank, you wanted to have money, and you had to queue in the bank to get money, and that was, at least for the last few years, the situation in many hospitals in the Netherlands. You had to wait to see a doctor, and digital contact with the hospital was not in place. So this is only a few years ago, and I think, well, we're going ahead in planning, and also in not the problem of the crowded waiting rooms. I think they diminished, at least during COVID, because we didn't want so many patients to be in the same room. So in 2019, we started the Isola Connected Care Center, and the main issues were that there was a report from Gupta strategists, and they warned us that if we go the way we did in 2015, we had to put one of each 4 people in the working age in care, healthcare, to cover the increase of healthcare demand. And that's impossible. It's now one in 7, and so we had to do something to add the demographic growth of healthcare, to put the healthcare issues in place. So we thought, let's start this. Our CEO asked me to start the center, and in the 5 years from now, we had a grow of I started with myself and one colleague. Now there are 15 people working in our connected care center, mainly on project basis, to help the departments in the hospital to get digital contact, but also hospital at home and virtual ward to get it in place. And at least during COVID, we had that was an engine that helped us to speed up all necessary IT demands that we needed in 2019. We had, it was bad, of course, COVID, but it also helped us. Yes, but how do you do this? Well, we started to, we're a lean hospital with a lean principle, and also with the principles of care pathways. We had them in place, and we all read the book Redefining Healthcare of Porter and Thijsberg. So many years we had in our hospitals we were working on care pathways, but now we had to redesign them, and we started 2 or 3 services to get this connected care center and the virtual ward in place. A lot of patients are outpatients that have outpatient clinic visits, and we can help them to reduce the number of visits with health education and self-management. If there little less stable, then we can introduce the second pillar, that is the telemonitoring. You can ask people to measure some blood pressure, saturation values, and register them in an app, and we can monitor that in our monitor center. I can tell you in a few minutes about that. And the most complicated group, but very interesting group, is people that stay for a long time in the hospital, maybe for an antibiotic treatment or for a not very high complex treatment. That's possible to continue at home, and therefore we introduced. Now we have 22 care pathways in which the patients, after a short stay in the hospital, is still under control of the hospital. Still, the specialist physician is looking after the patients, or the PA or of specialist nurse by our medical service center, but they are at home. Home care nurses, if needed, can treat them at home, for instance, for an antibiotic treatment and to replace infusions. So that's the three main services that we started at the end of, in the middle of 2020, after our first year. And I already mentioned the principles of value-based healthcare and redefining healthcare. And what we did is always asking doctors and nurses who want to introduce a connected care pathway, okay, let's look, what's your current pathway and how shall we redesign this pathway with help of, and that's the new part of it, which of the services that we have in place, is it more self-management, or do we need a device for monitoring, or is it even needed to get the virtual ward and a specialized nurse visiting patients at home to get it in place? And so that's how we redesign each care pathway. So the new standard of care is not after you get diagnosed, for instance, Mr. Johnson, who is diagnosed with COPD, who has an appointment each 3 months to see a specialized nurse or the physician. But the new standard in our hospital is you're diagnosed, and if it's going well, and if you do your registrations in your app, and these values are monitored by nurses who are in the medical service center at our hospital. And if you're all right, we can have a short contact, can have a phone call or even a video call, and if it's going all right, you don't need to come to the hospital. And we already did, with the help of students from the University of Twente, we looked at the reduction of carbon dioxide reduction in movements from patients to the hospital, and it really helps to get more sustainable kind of doing our healthcare work in healthcare. So this is from one of the consultants in the Netherlands, KPMG. We had them helping us during our second year of connected care, how we had to redesign our infrastructure, at least the infrastructure supporting the hybrid care network. So people are still ill. They need to go to the hospital. They have to have their CTs, have to get operations and so on. So that will be also in the future. People need to go to an expertise center, as we call it, but a lot of care and aftercare, and also rehabilitation care can be done remotely, but sometimes it's also needed to have a more frequent contact with the patients, and that's why we started a medical coordination bureau. It was started in October 2021 during COVID. And it's still in place, and there are 6 nurses now working at the coordination bureau. And as I told you, we have 22 care pathways in which we monitor and help patients for a short period of time, as an alternative for a clinical to be in the hospital. The main focus of our medical coordination bureau is an alternative for the admission to the hospital. There are other medical coordination centers that do more monitoring, low level or low complexity monitoring of patients who have, for instance, blood pressure monitoring, and also do that for GPs. And we are now exploring cooperation with these large volume, low complexity centers that are many years in place already in the Netherlands. Well, this was during COVID when we just started our monitoring, and these were the pathways. This is the early discharge pathways. That's what we mainly did, and this is for instance for COVID. Although COVID numbers are still very low currently in the Netherlands, and I think and hope we will never get the numbers that we had in 2021 and 2020 and 21. But this is the way we organized it. So we had a digital platform in place. We had our monitoring center. We had a nurse practitioner or medical specialist, and we monitored them until 10 days after discharge. But we also did at that time the preclinical monitoring, in which the general practitioner could ask to help for monitoring, and we didn't know if the patients got so bad that they needed to go to the hospital. But we were able to reduce the number of patients coming to the hospital for COVID. In the end, 15% of the numbers of patients, and it were about 300 patients we monitored preclinically. 50% needed to go to the hospital because of deterioration of COVID, but 85% could stay at home, including oxygen therapy, combined with the monitoring and the saturation monitoring by our monitoring center. And what they had to do is 3 times per day the saturation numbers by pulse oximetry, and once a day a digital questionnaire. So it was a big issue then, and we got into the newspapers in the region. But of course, this was only COVID, and we also thought we can do more and do prehabilitation. We have stroke now in place. We have a pregnant women who are very have nausea, and we get them on an infusion at home and get them antiemetics so they can stay at home and don't have to be rehydrated during pregnancy in the hospital. Important is that we want a thorough evaluation of the pathways that we redesign. And today, last year, the fifth, it's now the quintuple aim. Equity is added, but at least we started the last years at least to measure always patient experience, the health outcomes, the cost of care, and very important, what it does with staff experience. Staff experience is getting, well, it's getting worse and worse to get good doctors and good nurses and other healthcare professionals. So we don't want to convert into a digital way of working in which people, in which staff runs away because they don't like it. Fortunately, a lot of employees like this way of working because all standard and simple things are now getting away from your desk, and the more intriguing and interesting patients, that's the patient who you really see during a day. And about sometimes, for instance, for chronic renal insufficiency, our nephrologist is now working on the new outpatient ward, in which he says I can reduce the number of patients that I'm really seeing on a day with 40% by introducing digital help apps and people asking to go to do the lab. And if he sees the values, they get a very short message that it's all okay, that they're stable, and they don't need to come to the hospital. Well, but this is the story of the hospital. We realized that if you want to be really efficient, maybe we should more intensify our relationships with other care workers, at least the GPs, pharmacies, and so on in our region, because we collaborate and we get the patient at the right place. We introduced, and then we're working in a care network, and network care, that's, well, the next step in our connected care program. So instead of, we had a pyramid in which the pyramid was in which the hospital was at the top level, but after talking and talking, we thought, well, let's invert the pyramid. The normal pyramid that suggests that you want to be at the top and that the hospital is the best place to be, but it isn't. You want to be healthy. You want to be, maybe you have a little problem, and then you can manage yourself and stay healthy, and that's where you want to be as a citizen. So maybe the hospital isn't in the top, it's deep underground. That's what we thought about. So we inverted the pyramid, and we help, and our main strategy is to introduce positive health care, prevention programs, and so on. And we're now starting in our region with a big collaboration program in which we want to help patients to stay healthy, to prevent them from going to the hospital. And at a certain level, yes, you have to go maybe to your nurse specialist, or you have to go to a physician or a medical specialist, but we will help you. The main goal is to help you, including the telemonitoring, to help you as fast as possible to get back to your normal life, and maybe in a secondary prevention program, regain a more healthier lifestyle. And it's important to realize that the left upper side, there is it's Dutch. It's you see the Z and O. in Dutch, it's the zorgnetwerkomgeving. Well, it's the healthcare network digital environment that we're now getting in place and couple all different systems. We don't have a centralized system in the Netherlands in which you can see from as a GP or as a physician or a pharmacist what's going on with the patient. Everyone has its own system, its own digital system to do their declarations for the health insurances. And there are some standards to exchange information, but what we really need is a dashboard in which we can combine relevant data of patients that you need on a certain critical moment, for instance, at the emergency department, to see in a quick scan what's the main problems and issues with patients, including GP information, pharmacy information, and also comorbidity that's attached to this patient. So I hope next year we can, we're now working on it, but that this system, this network, digital network environment, that we can start next year. This is all supported by the integral care agreement that was issued in 2022 by the Ministry of Healthcare. And it's not all only healthcare, it's also about municipalities and welfare and sports. So we're now jointly committed together with social systems here around in the region to focus on less focus on disease and treatment, but committed to health and what you can do yourself before you go to the hospital. Very interesting program, and we're now running it for the last almost 2 years. And that's about also about the positive health spider plot, in which people are asked to fill in the spider plot, and that's the starting point for a discussion and a talk with the patients. So this is what you what you scored yourself on your spider plot, and let's look if there are issues that we can start and talk about and maybe work on to get healthier, a more positive way of staying in life. Well, after COVID, one of the big programs that started was post-stroke e-coaching for after a stroke. Of course, patients go to the hospital, get their initial treatment, but then it's very important to start rehabilitation very early. If you start during the first weeks after a stroke, it's possible to restore and to regain more functions than that you're waiting. So rehabilitation program to intensify it and to monitor patients day by day is very interesting, but also very labor intensive if you do it on site or the patients in a rehabilitation center. Yes, some patients and quite a few patients, yes, need to go to a rehabilitation center, but there are also patients who can do that from home, and we help them during 12 weeks after a stroke to do this program. It's very successful. We started it in our Isla Hospital in Zwolle, but it's now a program that will be introduced in at least 13 other hospitals in the Netherlands. I think it will become a national program, because two of the main collaborating hospital groups in the Netherlands, and we are part of one of them. It's called Improve. The other one is Santion. Together they introduced this, and well, I think it will also disseminate to the other hospitals in the Netherlands. Well, what's our focus? What's the next step? Well, what we did 2 years ago is we had many programs in place, and at that time we had a lot of monitoring also from the wards, nurses from the wards monitoring patients with apps. And we had a discussion about, well, what's the future? What does the future look like? Should we continue to monitor outpatients from the wards where their main physician is located, and or should we combine it to a medical service center? And what kind of medical service center do you need? And the medical service bureau that we started during COVID, it's on the right lower quadrant. That's more the high intensity monitoring, in which we we provide an alternative for a clinical admission. So we shorten the admission in the hospital by many days, and you need a quite trained, very skilled and trained nurses in the coordination center. And the 6 nurses that are working now in our coordination center at least have 8 to 10 years experience on a normal ward, and they all trained from ICU or cardiology departments. And so they also have a what we say in German, some Fingerspitzengefühl. They have the feelings if it's going well, and if they have a video call, they have, well, their gut feeling about if it's going well, or that maybe they should ask more. That's different from the more standard monitoring, like hypertension, the more general asthma monitoring, COPD monitoring, and stable heart failure, in which you ask patients not on a daily basis, but maybe on a weekly or monthly basis to do their questionnaires, and maybe add some monitoring values. And there are 2 big programs or organizations that started a few years ago in the Netherlands, and they're on a national scale. It's called Zorg bij jou, and that's healthcare or health close to you, but then in Dutch. And Altide, Altide or Altide is mainly doing a lot of monitoring for fragile people living at home. And they specialized more on the quadrant of more low intensity monitoring during office hours, and the volumes, of course, are very high. And if you combine it in a larger region, you can have maybe 100,000 people on the monitoring, but you speak them maybe only once a week or once a month. So we had a problem because high intensity monitor, low intensity, high intensity, with 6 nurses on a daily basis, we only have about 20-25 patients at max that are eligible for a virtual ward, and that's and we need at least 50 to 60 to get it cost efficient, because the 6 nurses are not only working during office hours, but also in the weekends. And that's why we started a collaboration with all the hospitals in the northern and eastern part of the Netherlands in 4 provinces. And we will next year, in January, we start with the Friesland region, and also with 2 big hospitals, including 1 academic hospital in Groningen. These are also big hospitals in which patients are treated for more complex diseases, get larger operations, but a lot of post operation monitoring can be done remotely if you use a medical coordination center. They're very much interested to do this together, and we also had it. We had a talk together and concluded that it shouldn't be the Isola Medical Coordination Center or the Isola Medical Bureau, but it should be white label together for all hospitals in the Netherlands. And that's the next step, what we're heading for the next 2 years to at least harmonize the care pathways, at least the 22 pathways that we have in place. It's very important to at least get in line with all the medical specialists and the nurses, that all the cut-off levels and so on and monitoring levels that we agree on action levels, and then we can centralize the monitoring, and the local physician stays and remains the physician for the patient, but the medical coordination bureau is the first line of defense. So, well, that's what we're heading for. Now, a little look forward. What are the most important changes that we see and have seen? I think what we now see, at least in low intensity, high volume monitoring, that within a few years there will be a lot of AI assisted triage, and that a lot of values and questionnaires that are built in by patients, that AI will help us and will help us to reduce the number of people, number of needed on a service center. These algorithms will also, I think, help us to decide if a physical appointment is really needed, or that we can do a remote, that we can do a treatment remotely. There will be more and more introduction of self-management, although not all patients are, and at least all the frail people, can be complicated to do self-management if you don't have a smartphone and you are not familiar with the use of apps. There is now we're more and more working with the libraries in the region, that this will be points where you can go and ask to help with to get more digital and to get it all in place. Interestingly, we also work on reduction of the number of patients that are treated on our daycare department, and very nice to see that for the treatment of patients who need infusions, for instance, not for oncology, but also for Crohn's disease or neurological disease. They have to go to the hospital now, to the daycare department, to get their infusion. But more and more companies are now also introducing subcutaneous administration, and that's very interesting because subcutaneous, the simple ones, you can learn patients to do the subcutaneous treatments themselves, and it can also be done by home care nurses, and you don't need to travel to the hospital. We're also working on shortening infusion times for large oncological treatments, so that it can be done at home or in a regional infusion hub. We now have three places, what we call hubs around the hospital, where at least short-time infusions are administered to patients. I think the regional collaboration will intensify. We more and more learn about what we do. We were very siloed until 3 years ago. I think the ICA really helped to learn what home care organizations can do and what's the value of a medical service center. We also introduced the quintuple aim and also look now on the impact on equity. And equity is, as you can see, it's a combination of on the right lower side. It's about digital literacy, health literacy. It has to do with social economical status, educational status, maybe disabilities and social marginalization. So I think it's good that that's also introduced in the quintuple aim. Oh, that was the end of my talk already. This is what we do at Zwolle, and I was introduced to do this talk by Gerrianne Leefding from the University of Twente, and I think it's very interesting to say that we have a intensive and also scientists in residence, as we call it, from the University of Twente, and also PhD students here who help us to learn about what's right to do and what's maybe not so right to do, because there's a big change. We have to learn sometimes. People come to us and have a brilliant idea. They think it's a brilliant idea, but if we look at the quintuple aim and we do a check, well, in the end, maybe it isn't as good as we want it to be. For example, one of our project leaders within our program, he looked at the smart patches. We had the company of Philips, of the Dutch-based, of course, Philips. You all know it from healthcare, and they had the patch, the smart patch, in which I think it was measuring heart rate and respiratory rate. And we discovered that, well, if you really want to monitor at home, it's not only about heart rate and respiratory rate. So these patches of 150 euros each, we didn't introduce it after a thorough investigation of PhD students. So I think it's very good to collaborate with the University of Twente.
Thank you, Dr. Maring. Thank you for that. And I'm afraid we haven't got time for questions because we're going to have to move on to the next section. But thank you very much for that. Some interesting things there around hospitals without walls, regional collaboration, working closer to home, and working with our population in terms of the acceptance of how we work through that. So thank you for that.
Yeah, thank you.
Just stop sharing the screen.
Yeah, stop.
Could you stop sharing your screen now, please, Dr. Maring?
I think it's stopped now.
Just 1 second, we'll just work through. Whilst we're doing that, I'll just work through the next bit of the proceedings. So we're going to move now into our breakout sessions, and just to be really clear with everyone, these breakout sessions will go on to 12:15. Then it's back here for lunch, and then we'll go on to 2 further breakout sessions this afternoon. So just to be clear now, breakout session for the Montgomery Pavilion will be building the evidence to address future needs. The international ground floor, which is just over the other side of the road there, will be the Welsh context of bilingual care. And then the first floor in the international pavilion across the road will be making clinical supervision accessible and effective in rural areas. So just to be clear on that, we're going to have to move straight on to those now. And as I say, back here for lunch following these breakout sessions, and then we'll work from there. Thank you, everybody. Thank you.
Of primary care, and also chair of the scientific board of EUREPA, European Rural and Isolated Practitioners Association. I also have a couple of other roles in that I'm also a council member for the World Organisation for National Colleges and Academies for Primary Care, but also for Wonka Europe. I am the lead for social prescribing and community orientation. So I'm here today to talk about EUREPA, but also in a way demonstrate how within EUREPA, the European Rural Isolated Practitioners Association, how it links with other regions of the world. So I'm also here with Jane Randall-Smith, who's the Executive Secretary of EUREPA. So when we've got questions at the end, we might go between the two of us. Working. Already.
Have to do that.
That's awesome. Specific problems with technology here. It's not clear. Not again. Not again. Yeah. Okay. So EUREPA was established in 1995 to address the health and well-being of the needs of rural and isolated populations and the professional needs of those serving those across Europe. And it's not only thinking about the Western Europe, we work over the Eastern Europe as well, far as Kazakhstan and other of the Eastern countries. So it's really thinking about, irrespective of location, it's about what the culture is and what resources are needed to address the health of these nations. Frozen again, apologies. So anyway, in 1995, it was established the development of EUREPA, starting of EUREPA at Grignog here in Wales. But then it was actually formally established in 1997. So EUREPA was recognised within Wonka Europe, as we were explaining about the World Organisation of Colleges and Academies in Europe. And it was a special interest group. But as recently as 2022, it became, we got membership of the executive board of Wonka Europe.
But also you have to think about, we're talking about one to Europe, but one also has regions around the world that we actually work with. And so it's thinking about not only how we're working within Europe, is that connectedness across the world and working with different areas such as Southeast Asia. So Eureka has 13 members from across Europe, and it also has an international advisory board, so it's a greater community of representatives from across Europe. And it also has the scientific committee, which actually helps with the development of not only the research agenda, but also the conferences to reach the integrity of the work that's going through there. And it's thinking about how within Eureka, we can actually make people or allow and collaborate across countries and enable research to go forward. And it's important that collaboration across Europe and to establish new initiatives to take forward, to think about policy, the education and training, research, and also most importantly, the impact on policy, not only in Europe, but globally. Okay, so thinking about the achievements of Eureka so far, and it's thinking that we actually meet every year annually across different countries in Europe. So this year it was in Dublin, and next year it's in Germany. So you're quite welcome. Oh, sorry, in Lincoln. Wonka Europe was in Dublin. So this year was in Lincoln. So, and you'll hear more about that later. But also next year, it will be in Wittenberg in Germany. So it's thinking about, and so what happens is members volunteer to host the conference. And it's thinking about, actually, by hosting that conference in their country, what impact it has within their country by hosting it. And it's thinking, it's not only people coming together, but it's thinking about how you create that kind of collaboration and working within those countries. So it's not only that, as explained before, it's thinking about how Eureka then works across different countries and different areas across primary care and within different organisations within Europe. Has it moved on?
Is that the one you wanted?
No. And it's really thinking about how we're actually helping GPs to take research forward. One particular one just recently was on vaccination. And so by working with Eureka, got responses from 32 countries. So it's thinking how you can actually work and actually help to make each conference makes a statement, and then there's also thinking about people and how they can take research forward and actually get collaborators from other countries. It's also what's been happening recently is having an impact on the international links. So from work within Europa, we've had an impact on the OECD and WHO on not only thinking about taking forward rural proofing, but it's also thinking about how we're looking at workforce and what the workforce needs are. And so it's thinking about not only having an impact on practice, but it's also important to think about how we have an impact on policy to make changes. But policy also needs evidence. And it's thinking about one of the initiatives that Eureka had is they actually developed the idea of taking forward social prescribing. And so by developing social prescribing in Eureka, went forward for it to come under Wonka Europe. And so it's a significant group within Wonka Europe. But within that, the group of collaborators within the social prescribing community orientation have worked together. So in the last year, they have achieved 6.97 million on a collaborative bid from the Horizon bid, another 400,000 from the Erasmus Plus bid, and another one from the EGPRN. So it's thinking about how, by working together, it makes a difference. And then you can not only do good research, but also gain the funding. So one of the initiatives for MIREPA is developing a blueprint for rural practice in Europe. And it was published in 2022. And it aims to set the vision and benchmark for European rural health for the next 25 years. And it's examined the key issues facing rural communities and health professionals who serve them. And it makes a number of key statements. And it's also thinking about underpinning the document, the need to address planetary health, but also MIREPA then links into Wonka World, which has a special interest group on planetary health and actually thinking about the future. So the blueprint actually covers a whole range of issues, thinking about the nature of general practice in rural areas, social care, how we link across areas, digital health. We've just heard a whole range of information about digital health. And it's important about, you know, what emergency services there are, the resource allocation, how we can have an impact on resource allocation by providing the evidence for that in the future. And so it's important to actually promote research and academic links across areas and actually thinking about the future challenges for rural health. So key message from that is rural health care must be seen through the rural lens, not from an urban area. And it's also recognising that rural practice is multifaceted. It's thinking about how we can develop team working, but also not only team working, how we can work with communities to improve their health. And so thinking about the wide range of skills is actually required. So another key message is actually having a workforce that's fit for purpose to meet the needs of the community and it serves, and also developing rural career pathways, not only for GPs, but other professionals. And thinking about how we have to think about how that will impact on the education of the future workforce. And also the leaders for tomorrow is thinking about how we mentor and coach the future workforce. So recently we had, as I got wrong, the Rural Forum in Lincoln. And it was actually hosted by the Lincoln Institute for Rural and Coastal Health. And it was about tackling health inequalities in rural and remote areas. But the discussion there actually said, you know, actually, what about coastal areas? We need to think about them, how that's impacted on erosion from because of the planetary changes, but also the changing in populations in different types of the times of the year. So the Lincoln statement was actually to help to achieve true health equality. And it's thinking about Europe, of course, for European governments, policymakers and rural stakeholders, not to think about one size fits all, but to consider to make recommendations that's fit for purpose for the different communities and also cultures across Europe. So it's thinking about how that works within their health systems, which are different across Europe. So some of the key messages from that is really thinking about empowering communities, and that's to make and co-create healthy futures for all. It's important to change education, to think about education and postgraduate education, but also thinking about within post registration courses, it's thinking about research. How can we have planned research programs within those areas? So instead of having a piece of research that doesn't go anywhere, think about how we can have planned research programs. And it's also thinking about the value in incentivization of the health current workforce, and thinking about recruitment and retention for the future. As we've heard in numerous times in the past, is thinking the health care workers in the communities are actually leaving practice. How can we make it more attractive and more healthier and to work and be active within rural communities? So thinking about the workload, promote integration and collaboration, and also the data gaps. We've heard this morning about, how can we use the data that's collected, because there's lots and lots of data, but actually it's not analysed and not used. And so it's thinking about what data are we collecting, and what's the purpose for that data that's collected, and how that can be used to provide evidence for government and policy for the future. Also in Lincoln, we actually set up the Rural Health European Academic Network. And that is the idea to bring together and establish a network of rural health academics across Europe, currently working in the fields of rural health research and multidisciplinary education and training for rural practice. So it's thinking about how we can set up this forum across Europe, and that forum of 17 countries that were represented. It's also thinking about having clinicians as well as academics, because you have to think about how things are going to actually work in practice. And it's also not only thinking about clinicians and academics, it's thinking about members of communities. They should be actually have a vocal voice within this. And we've got to try and develop the evidence-based practice to actually impact on policy. So giving the politicians the evidence to change practice, but also giving the knowledge to argue for that for the clinicians. And it's important to actually develop the education and training. And it's thinking about how, by gaining the evidence, we can actually have a voice to impact on the policy of the international organisations, the OECD, the WHO, and other international bodies, including the UN. And it's also thinking about, we would be grateful to have some representation from Wales. But also we've done a survey just recently of European members, and thinking about what are the important challenges that people are facing across Europe. And it's the most important one was workforce shortages. And then rural training pathways, and thinking about the lack of data, where's the data and how we can use it, but also about the ageing population, and also thinking about the social determinants of health, how we can impact on it. But also it's thinking about what they members need, and they want to actually be involved more in research and gathering the evidence, and also having being able to attend conferences and impart that information that they know to other people. And it's thinking about policy and also about collaboration with other organisations within Wonka, within Wonka world and within Wonka rural and within Wonka within the different regions. There are members and special interest groups covering a whole range of issues on mental health, respiratory health, cardiac health. So thinking about how it's not only what we're doing within Eureka, within Europe, it's thinking about how, you know, the different issues that needs to be addressed globally. So challenges for the future, and it's thinking about one of the issues is migration and people that are moving from Africa across Europe and going across different countries. It's thinking about how it's putting a strain on different communities within Europe. And it's also thinking about the conflict and war, the impact that's having across different issues. We do have members in Ukraine and within the surrounding areas that are having to deal with the migration from Ukraine and from Russia to because of the conflict there, but also the conflicts in the Middle East. But it's also thinking about, you know, climate change and the impact that's had. And it's about the equity of people, mental health care, the end of life care, and it's the digital inequalities. People are talking about, you know, we heard before about, you know, internet banking and other having to doing things over the internet, but that's not necessarily quite favourable for everybody to think, well, you know, actually I can't walk down the road, I can't go anywhere, I have to do it on the internet. But the idea of going to find out how to use my, you know, digital to go to the library, to actually look at my healthcare records, I think I find it a bit difficult. So it's, but then I'm the older generation. So it's thinking about it doesn't not necessarily fit for everybody. And it's thinking about not only the impact that COVID-19 had on communities worldwide, it's thinking about the future pandemics. How are we going to address it in the future? But not only that, it's the healthcare implications for the professionals that caught COVID and now not able to work. There's a whole range of issues. So why join Eureka? Can I do good sales? It's thinking about, you know, really about, there's a whole host of issues going around that we actually get involved in, and people, different organisations contact the Eureka to actually have an input into, collaborate with for the future. And it's thinking that we do have an annual forum, that people do attend from across Europe to talk about different issues, to think about collaboration and discuss future practice. And the do have the WHO attend the meetings. And it's thinking about the developing research initiatives across Europe and thinking about the European context. And it's networking, it's talking to people, meeting people from and discussing and developing ideas, because sometimes it's just, you know, the idea of sitting down over dinner. We do have a dinner with these forums, and really talking about ideas and actually making them formulate and think about how people can work together for the future. And it's thinking about career development. It's important to think about careers for the future. Which are the best ways of addressing different conditions, and who's the best practitioners to do that. But and it's thinking about, you know, the careers, the development ideas, but also sharing and working together discussing experiences and how these can be addressed. And it's also, most importantly, is thinking about advocating for good rural health and access and outcomes for the future. So, as a Wittenberg, next year in the 14th Eureka Conference, the 26th to the 28th of June 2025. So open for call for abstracts in the near future. But also, if you want to become a member of Eureka, here is the website. Is that a whistle-stop tour?
Thank you. Thank you very much for that. A very whistle-stop tour, actually. I think, yeah. So, and we have got a few minutes for questions. Yeah, we've got a few minutes for questions. So, so that's good. And did I see a couple of questions pop up online anywhere? Did I see a little window pop up somewhere with questions? Any questions in the room before we do an online look? Interesting, isn't it? That kind of policy influence, and how do you actually influence policy that's, you know, particularly in a European sense now as well. It's a very different and interesting world to do the influencing in, really, isn't it?
But not only that, they're actually wanting us to input into it. And one of the from the World Rural, it gave me access to actually have an input on rural health in the world, the State of the World's Nursing report. And it's thinking about how you can actually not only verbally do it, but write it. And I've learned from being a previous role into the Welsh Government to take forward research initiatives, is thinking about how you can actually input into writing policy.
It's good. Questions online?
There is one about British Sign Language. Can you read it there?
I wish I could.
Encouraging communities to co-create healthier futures and fit for purpose workforce, knowing the importance of British Sign Language within our communities and workforce will go a long way in making this happen.
This is about British Sign Language and the future and the use of British Sign Language, I think, going forward. Have we had any input, or is there any thinking going on in Eureka around that?
No.
No, there's a shake of a head coming from that.
No, we haven't. But it's also, you know, we have, it's working across different cultures, and also thinking about, I'm lucky that I speak English, but also it's thinking about how, you know, we can collaborate across languages as well. So it's thinking that people do have to, you know, when we're doing different research projects, it's thinking about the translation and making sure that there's no problems with the translation from one language back into another language. And so that in actual fact, if they want to take part in an international research project, how we make sure that we're actually speaking to the same ideas and understanding of issues. And I think it's important that that's
yeah, and I suppose that question is around other communication mechanisms and how we make sure that we include those in that picture, isn't it? It's not just the many languages that are spoken, but it's that sort of alternative methods of communication need to be in there as well. And I'm sure that point has been taken away in terms of this morning. Yeah. So is there any other questions now before I?
No, there's a lot on previous talks that we didn't have time to do questions on.
Yeah, okay, that's great. So thank you very much for that, and I'll give you that back. Thank you ever so much. And I think now we are moving on to, in fact, we're 1 minute late, moving into lunch. And I would say that lunch has been extended slightly today to enable the posters to be viewed and scored. And if we could take that time to do that, that would be really useful. Thank you all very much. And we're going straight into breakout sessions after lunch, which I'll come back to you on as we get towards the end of lunch. Thank you. Take your seats for the next flight. And we're having 2 sessions now, aren't we? So we'll need to make sure the changeovers are right. To make that happen, Anna, you'll have to pick me. So I'm just going to quickly now then ask everybody to move that's moving. And I'm going to hand over to Emma, I think. Is that right?
Yeah.
Okay, Emma, over to you.
Oh, wonderful, thank you. So proud hour, everybody. Thank you for choosing our session, and it's great to see you all here today. So within this session today, we're going to discuss our experiences of establishing general practice placements for our pre-reg students, nursing students within primary care settings. So my name is Emma Roberts, and I am a regional primary care practice education facilitator working for RHCW. And I've also got a background within primary care as an AMP. So we know it's vital that we secure a future primary care workforce, and that within the current climate, which is quite tricky, it's also having a significant impact within our most rural areas. So RHCW in 2021 completed some scoping work, and it found that 54.4% of our really highly experienced and skilled practice nurses are now over the age of 55. And we've been through a challenging couple of years, so many of them now are considering reduction of hours or even retirement. And of this 54%, interestingly, only 3.1% of these practice nurses are under the age of 30. So the Health Foundation, further to this, estimates that a quarter of all GPM posts could be vacant within the next 10 years. So quite startling figures, really. And when I came into post in October 2023, 373 GP practices across Wales, out of all those GP practices, only 18, so 4% were offering pre-reg student placements. That's such a small amount. So that's despite 2,300 nursing students entering the programme annually, meaning that very few of our student nurses were getting any exposure to primary care placements. Thankfully, the picture is changing, but we've still got a long way to go. So we've been heartened to see that with the right supportive measures being put in place, that GP practices are really eager to engage and showcase their services and to really play a part in influencing our student nurses' career choices going forward. So there's been a number of challenges presented by our GP surgeries. Or is it going forward? It's not changing.
Is that which one are you supposed to click it? So,
yeah. Oh, there we go, changing. So there's been a number of challenges that were offered by our practices as to reasons why they might not be able to host student nurses. These have been workload pressures, financial costs hindering placement offerings, releasing staff for training was a big one, ongoing support and time taken away from clinical commitments. And they also said that they often feel like the whole process of setting up and completion of the governance process complicated and overwhelming, especially at a time when they're already stretched and feel like they're fighting fire. So this, coupled with the Healthier Wales vision that places a greater emphasis on shifting services out of secondary care and into our communities, alongside the 6 key priorities set out within the strategic programme for primary care, have only compounded the workload pressures and impacted on our already existing workforce and services. However, very much highlighting the need to future-proof our workforce in Wales going forward. So how we address this within RHCW? So with the introduction of my role, the Regional Primary Care Practice Education Facilitator, and there's 3 of us that were put into post in October 2023 to address these placement challenges. And our focus really has been around nursing students and ensuring that sustainable general practice nurse pipeline. And I'm really pleased to tell you today that we've increased our placement capacity from that initial 18 up to 63 active placements, so placements that are supporting students at this moment in time. And we've got a further 32 practices that are currently working through the governance process. So should be ready in about 3 months' time. And we've had so many expressions of interest as well. So it's good news. We've also had a key focus on engagement and collaboration with our stakeholders, and that's been really important to us. So we've received a really warm welcome across the whole of Wales from our primary care academies, from our higher education institutes and our health boards. And they've really been committed to pushing forward this shared vision. So this approach has ensured that we're able to expose as many of our workforce of tomorrow, so people like Alex, to high quality general practice placements, hopefully inspiring them to consider a career within in this area going forward, and maintain that really important pipeline. Oh, it's gone too fast.
I want to take the.
We've gone to the end. I think we're here. So I might be very biased, having worked in primary care, but I have to say we're quite amazing within primary care. And as such, we need to be flying the flag more, because we don't tell enough people about it, about our hugely knowledgeable workforce, our ability to harness a multi-professional approach, our innovative services that have been developed in response to patient need. You know, we've got a clear pathway for our newly qualified nurses that takes them through the foundation GPN course, the upcoming SPQ that's in development at the moment, right through to potentially nurse consultant level. Where else in nursing do we have these pathways? And we also need to emphasise the attractiveness to our students of practice nursing to deliver that work-life balance and really push practice nursing forward as a first destination career option for our student nurses. So alongside the measures already discussed, RHCW recognises GP surgeries should be appropriately reimbursed for time lost supporting students. So paid placements generally last between 4 to 10 weeks. It varies across Wales, with an average of an 8-week placement equating to £1,000 per student nurse. And it's also been recognised that often surgeries perceive the process, as I've said before, as overwhelming, complicated and time-consuming as setting up as training practices. So in response, our roles were implemented to support surgeries and make the process as easy as possible at every step of the journey. We offer bespoke on-site training, so we come out to the GP surgeries and we plan packages of training for the staff, meaning practice assessors and supervisors can be trained on-site and don't need to go out for 2 days. And it can be tailored to the individual needs, so we can RPL experience across. And it's working really well, I have to say. And we know that hosting students also allows for a grow your own approach. And it's been found from previous pilots that many of the students that have experienced primary care placements then go on to take up roles within primary care environments, many of those staying in their placement areas. So it's that's what we want. And I have to say, the data, both qualitative and quantitative, I would have loved to have shown you more today, but I've just not got time, has been overwhelmingly positive, with many of the practices expressing the benefits of supporting students and the practice nursing teams reporting increased self-satisfaction and confidence within their roles. And our students have evaluated the placements really positively. So I'm going to hand you over to Alex, who's going to offer the student voice and tell you about his experiences. Yeah, Alex.
Thank you, Emma, and thank you all for coming to listen today. There we are. So moving on to real life student experience, I'm Alex, a second year full-time nursing student studying adult nursing, and I was lucky enough to be able to spend 8 weeks working at a GP practice in Tenby. So before this, I had little to no experience working in primary care, and in retrospect, about only a half-baked understanding of it. So having the opportunity to experience this placement was the definition of eye-opening. As a student, it allowed me to gain an understanding of primary care and work within a diverse range of professionals and to develop my practical skills. One of the key takeaways from this for me was learning how to better build a therapeutic relationship with my patients through holistic practice. As a student, I was encouraged to see patients across a variety of departments, whereas in secondary care, often you get stuck at your end of the corridor. In primary care, I was able to see patients not only across different clinics, but across different settings entirely, going out into district nursing and minor injuries units and really being able to follow patients through their healthcare journeys. One example that stands out for me was a patient who we'd seen a lot in blood clinics, and I was lucky enough to there also see them when I was in an asthma clinic shadowing the nurse there. Of this half-hour session, we probably only spent 2 to 3 minutes of that talking about asthma. The rest of the time was spent discussing this patient's mental health difficulties and the steps they'd taken to come alone to this appointment today, and the steps we could take together to further support them in their journey. I found this very rewarding and an insightful look into this patient and how they manage both their mental and physical health conditions that they struggle with. Alongside the personal, I was also able to build on a lot of my key practical skills that you need to get signed off as a student nurse. So the GP practice was truly the perfect placement as me, someone who's just gone into my second year. I had this whole list of competencies that have just opened up to me that I couldn't wait to get my fingers onto. Top of that list, of course, being venipuncture, taking bloods off people, something that could be a bit of a struggle to get signed off in secondary care, as dependent on which department you're in, it only comes around about once in every blue moon. But I was lucky to be able to jump straight in, feet first into this, joining in from my second day blood clinics daily. And we totaled it up just to see. At the end of my placement, I'd done just under 200 blood samples, and I felt I'd really achieved that competency. In addition to this, I also had the opportunity to sit in on wound care. Now, practice nurses are truly the gospels of wound care. They know everything about it under the sun, and they've really instilled me with that passion for that area of nursing. And much to the horror of any guests that come over now, we now have the Hellvale wound care formulary pinned up in our kitchen with a wonderful array of grotesque pictures for me and my guests, well, me to enjoy, perhaps not my guests. These clinics allowed me to achieve many of the key ORA skills, which are skills that you as a student nurse achieve across the 3 years of your training that are very practically based, such as wound care, aseptic non-touch techniques and injections and medicines management. I gained an exposure to a myriad of wounds and appropriate nursing assessment and treatment planning, and towards the end of my placement, I was even given the trust and responsibility to have my own small supported clinics, which I found immensely valuable. I was able to follow up on patients I'd met previously and learn how to implement the care plans we had created. This did wonders for my confidence and my ability to put into practice what I'd learned in theory. And building off that was the ability to teach what I had been taught. So health promotion is a very vital part of nursing and healthcare, as we all know, but an area I'd struggled with previously, as I didn't really feel as a student nurse that I had like the right to tell a patient what to do. But this was a placement that definitely taught me about that and how to pass on the knowledge that I had learned to my patients in a way that was beneficial to them. Passing my knowledge from dedicated interprofessional learning was very useful, and there was a lot of opportunity for that kind of IPE that we always talk about, that interprofessional learning in this placement. Another example that stands out for me was the time I got to spend with one of our paramedic practitioners, Jilly, who was doing self-funding a master's in mental health. I was able to sit in on her clinics on mental health, and as someone who's more focused on the adult side of nursing, it was very enlightening in terms of common conditions and red flags that I, as an adult nurse, could look out for in my patients to do with their mental health, and also gain an understanding of the resources available for those patients if I want to refer them onwards. And all of that discussed that I've mentioned now helped build this safety net to make me a more independent worker while still having the support that I needed. So building off of that, this placement really allowed me to understand how different parts of primary care work together and work with secondary care, improving my understanding of support and services available in the community and understanding holistic practice. So often in secondary care, despite our best efforts, we lack the time to spend that one-on-one time with patients and create those individualized care plans that we dream of. But in primary care, especially as a student there, someone supernumerary, I was able to really spend a lot of one-on-one time with those patients and create those care plans. I went through all of this side by side with a diverse range of professionals throughout my placement. I worked with pharmacists, pharm techs, physiotherapists, doctors, paramedic practitioners, the list really does go on. Students from all those different professions, phlebotomists, and a myriad of different specialist nurses across a variety of areas. And the teaching they did to me was so valuable because they're people who are so passionate about their subject areas and so eager to pass on that knowledge. And they love having students, and they're very willing to put up with my incessant questioning about everything they tell me. And that learning very much went both ways in terms of often, especially in roles that had less to do with the nursing side of things, they would have questions for me on what my role is and how our training compares. And I especially remember working alongside with a pharmacist student. While she was blowing my brains with fascinating scientific facts about drugs and medicines management, I was teaching her about the physical side of things, working with patients and taking manual blood pressures, which was an incredible experience. In summary, this placement and style of placement is very conducive to learning practical skills and understanding the ins and outs of primary care. It's also a key place to engage in the in-depth interprofessional learning that we really want to build on and to grow clinical confidence. I stepped away from this placement feeling that I'd properly grown into the role of a student nurse and a nurse in general, something that I hadn't felt before. And I feel this would be a valuable experience for other students also. Thank you very much. Now I'm going to pass on to Betty to talk about the universities.
How do I follow that? Na'n da bawb, I bawb sydd yn ystafell ac I bawb sydd ar-lein. Hello everybody, and can I say thank you for the opportunity to be able to present here today in this conference. So Betty Weil, or Elizabeth Weil yw enw fi, that's my name, and I'm a community lecturer at Aberystwyth University, a post I've had now for the past year and a half, being one of the ones over 55 who's already retired ones. So general practice placements are new to Aberystwyth University and they've been really welcomed by us as an institution as well as by the students, as you've heard with Alex. And it's also been marvellous working in partnership with RHCW. I initially worked with a lady called Holly Powers and now with Emma Roberts. So our first batch of students have finished working out in the placements. And the catchment areas, the following surgeries with us have come on board: Tenby, Ystwyth Surgery in Aberystwyth, Kidwelly, and Kidwelly covers 3 surgeries, so Pontiacs and Trimsaran, Furness and Carmarthen, Adpar in Newcastle Emlyn, both and Tregaron as they joining up as one placement, although there's miles in between, but we really do have to try and be flexible and innovative in the way with our approach to make things work. And also Cardigan. And in Cardigan, that's been a different way of working as well. The student who was placed there might have been in placement with general practice for 2 or 3 days a week, and then the other 2 or 3 days were spent in minor injuries. So we really do try and work flexible to support the practices as well as giving the students the best opportunities. So from the first cohort, you already heard from Alex, and on this slide there are 2 other students that I'll refer to, which is Cheyenne and Alana. Cheyenne was in town in Ystwyth Surgery, and Alana was out in Kidwelly practice, going and moving around between 3 practices. So from a university perspective, the challenges, one of our main challenge, I think, is arranging placements. This is due to the rurality of our catchment areas. And obviously our local hospital is very small in size. And also the recent closure maybe of homes and community health beds. For example, Tregaron Hospital closed recently, so that's no longer a placement for our students. So finding placement is truly a challenge. Also securing accommodation. Along with finding the placements is transport as well. Lots of our student nurses don't drive or they don't access a car. Even yesterday, I had personal tutor time with a student who wasn't travelling too far to placement. He was from Aberystwyth to Cynhadledd via train. But of course, that became an issue for his placement recently, because you might have heard of the recent train accident that happened. So that put a bit of spokes, made it a little bit difficult. Also, a lot of our students have caring responsibilities. They might be single parents or with caring responsibilities, and they need to have their placements closer to home. Accommodation, finding securing appropriate accommodation is also a challenge. For example, once one of the placements is Llandyfri, and the student was due to go out there around the time of the Royal Welsh Show. Well, there was no chance of us getting any accommodation anywhere near close to the area. And of course, there's implications then, because our students do have to travel quite wide. There are implications cost, because they have to travel. There's a lot at one time, given time in Haverfordwest, maybe in Withybush Hospital, in Brecon Hospital. Undertaking this now and preparing for this conference today, until you sit down and look at things. For example, if I told you we've now got 3 years of student nurses in, Bronglais Hospital is a relatively small hospital, and at any given time we only have 20 placements there for our nurses, and that's shared between Swansea, us and Open University. So that is the challenge. So we really welcome this new learning opportunity and experience in GP practice. So there's no formal placement arrangement with Bexy Cadwaladr. So our catchment areas, all of Ceredigion, Bexy Cadwaladr, which covers like Tywyn and Dolgellau, and then we have 10 placements with North Powys, which covers Rhaeadr, Brecon and Welshpool. So the benefits. Our student nurses go out to GP practice in their second and third years. And the benefits is, obviously, it's a new learning opportunity for our student nurses, and we've really heard from Alex how he's found the benefits for himself. For practitioners, learning is a two-way process, and it helps to ensure that our practice is current and all evidence-based. I really enjoyed, when I was out in practice, having students, because I used to say they keep me on my toes. And then joint working with HCIW, that's really been positive. And hopefully all of this will aid the recruitment of student nurse placements will aid the recruitment of practice nurses in the future. So prior to asking the student nurses about any challenges, I asked them, would you recommend this as a placement for student nurses? I saw each one of them separately, and all their answers were 100%. They didn't give me another answer, it was 100%. So that's so positive. The challenges that they talked to me about was, we've talked about rurality, transport accommodation, the training of practice supervisors and practice assessors, especially if people move from their roles. One student nurse said working 9 to 5 wouldn't be her choice, because obviously a lot of our students are on bursaries, student finance, so they'd really have to work somewhere for a day or to do a healthcare support worker role, which she found difficult, working 9 to 5 Monday to Friday. And the other student said you do need a car to travel in between surgeries. So they were the only challenges that were mentioned. So Cheyenne and Alana, who you saw at the front, These are some of the comments that they made to me, which I think really echo what has been said by Alex. Alana always wanted to be a community nurse. She came into nursing wanting to be a community nurse, but she says that this placement is a favourite placement so far. And she's hoping to have a third-year placement with a practice nurse within a GP surgery. And also said that the role of the practice nurse would have never been on a radar. So although we walk into GP surgeries, that role was never on her radar. And as Alex said, the perfect place to build the nurse-client relationship. Felt very much part of the team, always involved. And we must congratulate the surgeries. This was their first time they've had student nurses, and each one of them came back and said how involved they felt part of the team. They've all said how many of their proficiencies, auras and interprofessional hours they've been able to tick off. And they've also learned, they all mentioned diabetes. Diabetes is a huge subject. So unless you're working with a diabetic nurse or on that ward, you know, your knowledge might not be so good, and they all have felt they've gained so much. So looking ahead, hopefully we can build on this initial success and that we can scope additional GP practice opportunities. Got to say about funding the importance of investment into the role of the primary care PEF who takes their bespoke training. And hopefully then we'll have a sustainable workforce within primary care. Diolch yn fawr am wrando. Thank you very much. As os gyda rhywun unrhyw cwestiynau, any questions, I'm sure that the panel will be glad to answer. Diolch.
Thank you for that, and again, really bringing home the need to be able to explore possibilities and to try a different way. And one of the things we need to be really clear on, I think, is if we hit a brick wall, we've got to find a way around it in our new world, because otherwise we just continue to do what we've always done, and then we wouldn't have had placements, and then we wouldn't be able to develop people, and then the number of students coming into the system would drop, and then we'd end up with not achieving where we needed to get to. So those brick walls are there to create the challenge. They're not there to stop us, I think is important. Are there any questions from the floor before I open up online? No? Okay, thank you. Anything? Oh, sorry, there's one there. Have we got a microphone? Michelle? Thank you. 1 second. Just here. There.
We answer in English or Welsh?
You need to come over to the left.
Right.
You want to repeat the question first?
Yes.
I don't think they hear it online.
Yeah.
I didn't hear it online.
The question I had was, have we had any difficulties persuading or getting the students to go out to primary care? Not at all. Not at all. And I think after now they've shared their experiences as well, I think they'd be they might be fighting for their GP placements for the experience they've had. Yeah? Yeah.
Great, thank you. Thanks for that. Any other questions online?
Just a lot of favourable comments, and it's inspirational, great achievements, fantastic, well done.
Inspirational comments from online, lots of friends. Good stuff. So thank you all. There's another question over here. Just 1 second, 1 second. 1 second.
I just wondered, was there any problems with if the students is English speaking and they have a basic exposure?
Alex, do you want to come and tell us about that challenge? Would that be okay?
Can you repeat the question?
So the question was on if there is any challenges of being an English-speaking student, perhaps going into more Welsh-speaking placements. Speaking that, I'd say that wasn't a challenge I encountered at all. As I'm sure lots of you know, if you don't speak Welsh but you're willing to learn it, everyone will immediately take you under your wing and insist on teaching you Welsh the proper way. And I never had any issues with it from any patients on that area. And I feel like I managed to pick up a lot of Welsh in placement and in practice, just from speaking with patients and with staff. And you can tell it means a lot to both of those groups to be willing to undertake that learning. And I think that's a feature of these placements rather than an issue with them. Thank you for your question.
Thank you, Diane T. Any other questions online? Okay, any other questions in the room? No, great. Thank you very much indeed. We're now going to shortly move on to our next presentation. We've got a little bit of a break, have we?
15 minutes for people to move.
Yeah, 15 minutes would be, if we could, we're going to move people round to our next lot of sessions. So we're going to start the next presentation at 1:15, if that's okay. Thank you. Okay, everybody, if you're ready, we will continue on. I think we are linked up with Canada, are we not? Ready to go? Good, excellent. Okay, so we're going for our third breakout session now, and hopefully Alexandra will be online and will join us now to talk about connecting people and community for living well. Alexandra, over to you.
Perfect, thank you so much. I'm just gonna quickly share my slides here. There we go. I hope everyone can see the slides now.
Yes, good.
So yeah, thank you. Perfect. Yes, thank you for inviting us again to present at this conference this year. My name is Alexandra Timchuk. I'm the research coordinator for the Connecting People and Community for Living Well team. I'm joined today as well by my colleague Blair Wold, who is a senior practice consultant for the team. And today I'm just going to give a brief presentation about the well-being of underserved populations in rural communities. So just to set the context a little bit. So we are from the province of Alberta in Canada. So the province of Alberta is quite a big province. It's about 662 square kilometers, and we have about 4.4 million people. So quite spread out throughout the area. We have one regional health authority known as Alberta Health Services, and our healthcare system is publicly funded, so it's based on the needs of individuals more so than what people can afford to pay. But our social care is a bit of a combination of publicly funded services as well as government services, and also community services and non-for-profit services. And since this presentation is focused on the rural context, just to give you guys a bit of an understanding of how rural Alberta looks like. So those living in rural remote areas may be required to drive up to 2 to 3 hours to get to the nearest urban center to get to go for bigger services, healthcare services, social care services, and in some areas such as northern Alberta, it might take them up to 5 to 6 hours to drive to the nearest urban center. So in the previous grant, so from 2020 to 2023, my colleagues were interested in what impacts the well-being in rural remote communities in terms of people's living with dementia, their carers, and the collaboratives. And through that work, they were able to develop the Connecting People and Community model. And now this time around, from 2023, 2020 to 2026, we're interested in taking that same model and scaling up to new populations in Alberta. So here's just a high-level overview of that model. So at the end of the day, it is focused on supporting the individual well-being as well as the collective well-being in the communities. So here we have 5 different domains of that model. The first one is provincial support. So it really connects back to finding different partners throughout the province, whether that's community services, non-for-profit, governments, to support the work. The other part of it is community activity and advancing their work. So helping different communities advance different programs, different services. The next one is the 10 core principles. So that really has to do with making this community driven, community led, and making sure that what we say is that when we see one community, we see one community. And then also developing a, sorry, I have a bit of a cough here. My apologies. So developing a well-being guide. So this helps communities to determine what is necessary and just what impacts their well-being well, what doesn't impact their well-being well, and what can be done to improve in the community. And then also a competency framework. So what can be done to improve that collaboration between different sectors in the community. Sorry, I'm just going to take a bit of a water break here. So for this project from 2020 to 2023, we're really focused on underserved populations. So taking that model that I just presented in the last slide and scaling up to different populations in Alberta. And in particular, we were interested in underserved populations. So by underserved populations, we really looked at the health equity and policy definition provided by the University of Pennsylvania. And for that definition, they are interested in individuals that face any sort of barriers, whether that's economic, racial, ethnic, gender, in terms of accessing their public health needs. So to get started, we really looked at the literature search to understand what underserved populations exist in Alberta. And then also we talked to different interested rural and remote communities in Alberta to see what kind of underserved populations exist. We ended up working this year with 4 different communities that focused on 4 different underserved populations. So the first community looked at individuals experiencing low income and housing insecurity. Another community was interested in older adults 60 plus. Another community looked at newcomers. And the last community looked at women experiencing domestic violence. So in terms of data collection and analysis, we started off by conducting focus groups. Each focus group had about 4 to 10 participants. And the only requirements is that participants were 18 years of age and older, but also that they have that lived experience. And so for the focus groups, we really were interested in understanding what impacts their well-being in the community, what could be improved, what's missing, and any gaps and stuff like that. To analyze the data, we referred back to Alistair McGregor's well-being model that he developed back in 2007. And that model really helps to categorize well-being into 3 different domains with separate subdomains. Those domains are material well-being, relational well-being, and subjective well-being. So just kind of to quickly go over it, material well-being is what one has. So that includes housing, transportation, income, the time and space in the community, so those built environments, those natural environments, and also their accessibility to those things. Relational well-being refers to what one can do through their relationships. So that includes family, friends, relationships that they have with their social care network, their healthcare network, as well as within the broader community through social engagement. And then subjective well-being really refers to how one feels about what they have and what they can do with it. So it really ties back to their psychological health, their ability to handle transitions in life, and then also their sense of identity. So now over the next couple of slides, I'm just going to quickly summarize what we heard from the participants in those focus groups. So when we talk to individuals experiencing low income and housing insecurity, when they discuss their material well-being, they really talked about that outdoor built environment and how that impacts their ability. So especially in the winters, if the sidewalks are clean and there's no slipping hazards or preventing risk of injury, as well as are there benches, are there public washrooms, warming hubs, also transportation. So a lot of these people don't have access to vehicles, so being able to drive out of the community to go to a larger urban center for their healthcare appointments, or having accessibility to affordable taxis, because it's quite expensive to go from a rural community to a larger urban center. Also housing options, so in terms of low-income housing options, as well as temporary shelters available. Financial services, so some of the participants talked about being able to apply for pensions or their CPPs, and then also job opportunities, being able to get hired by others, and also maybe to start different business opportunities. A lot of them were skilled in different areas, whether that was sewing, and to be able to contribute to that to the community while also being able to make income. So the relational well-being, they discussed their relationships with family and friends impacting their well-being, also the relationships with the collaboratives in their community, and just also the social networks that they were able to develop with others in the community that are also maybe experiencing low income and housing insecurity, and how they're able to help each other out. In terms of subjective well-being, they really talked about their individual worth. They did talk about feeling invisible or just not being paid attention to, feelings of isolation, feelings of loneliness. Then they also really talked about different physical health changes, workplace injuries that they've sustained that really impacts their ability to work and also to contribute to the community. Moving on to the next group, the older adults 60 plus. So in terms of material well-being, they did really talk about that space, those built environments, so having access to recreational facilities in the community and having those programs for like fitness programs for seniors available, also having access to a community garden to be able to participate in that in the summer. They also talked about transportation. So a lot of these individuals have to drive out of the town to go on a highway to go to the nearest urban center to buy their groceries or to go for their doctor's appointments. Housing, so having affordable housing, but also a senior level housing available in their communities, not having to move away once they reach a certain age. And then also a service directory, so just having that information compiled somewhere where they could see, for example, if they need someone to help shovel their snow or to mow their lawn or to do any maintenance around the house, such as fixing a fence, that they know who to contact in their community for that. In terms of relational well-being, they did talk about having connections with their local council team and still having a voice and having an impact on what happens in their neighborhoods, in their community. And then also just those social networks that they develop through the regular community events. In terms of subjective well-being, they did talk about how that well-being is really impacted by their length of residence in the rural community. So a lot of them have been there for generations, for many years, and also what they've contributed throughout their time in the community. A lot of them had very prominent jobs. For example, they were the community librarian or, for example, the firefighter. And then also they did talk about how the changing dynamics of small communities does impact their subjective well-being in terms of the cost of living going up or just the overall changing demographics. For example, a much larger prominence of a younger demographic, teenager and young adults being more present in the community. Women who have experienced domestic violence. So they did talk about a lot about safety measures, safe spaces in the community, being able to, for example, even go to a grocery store or for a medical appointment or to a washroom and being able to see, a QR code or like a helpline just to know who to contact just in case they need any help. They did talk about affordable housing and women's shelters. So a lot of the time, if they need to go to a women's shelter, they need to go into a larger municipal centers, and sometimes those are over capacity, so they might have to go to another larger municipal center. And then also they talked about the coordination of resources, the legal system, being able to have an access to a lawyer, to restraining orders, to all of those legal documents. They did talk about, in terms of relational well-being, the relationships that they have with their employers, with their friends, with their service providers. These are usually the first people that are able to help them with those legal aspects, or to help them take time off of work, or to get a cell phone, or whatever safety measures they might need. Also, the relationships they have with other women who are currently experiencing domestic violence, or who have experienced domestic violence, to work together in the community to sort of to do some advocacy about that, to bring awareness to that, not only to healthcare providers, but to business owners, and just to government people as well, in order for them, to city council members, in order for them to make it a priority. In terms of subjective well-being, they did talk about how their identity is very rooted in their relationships, and it impacts them a lot because of the complex transitions, going through a separation, having to move their kids to a new town or to a new school. And then they also talked about their psychological well-being, overcoming that guilt, that PTSD, and also the trauma that may come from their experiences. And then the final group, the newcomers to rural communities. So they really talked about that initial housing options, being able to come here and get that initial housing before maybe moving into a home that's larger, if they are planning on expanding their community, or they're coming with children. They also talked about transportation. So a lot of the times in these rural communities, there isn't established bus route, or a lot of the time they have to travel outside to other towns for their work as well. They did talk about the cost of living. With this rural town in particular, it was in northern Alberta, so the cost of living in those areas is much higher in comparison to other parts of the province. They did also talk about the outdoor environment. So in terms of feeling safe when they go outside, some of them are not used to seeing the presence of wild animals such as bears or moose out and about. So just having that awareness and knowing what to do when you encountered such wildlife outside. And then also spaces and activities for their children and their families. So having access to recreation centers, to schools. And then in terms of relational well-being, they did talk about the relationships with their employers and colleagues. Usually, if they do come here for work, those are the first individuals that they're able to have any sort of relationships with. And those are also the first people that usually help them to get accustomed to the town, or to help them, for example, if they're coming from a different country, to help them get ready for the winters. And then also they talked about the ability to make relationships with just different people in the community, whether they go out for coffee or they go out for dinner, to be able just to naturally meet other people in the community like that. And then also they talked about being able to build with others that may be from their same cultural communities or ethnic backgrounds. And then in terms of subjective well-being, their well-being is very much impacted by the anxiety and stress that they have in terms of moving to a new country and learning all about Canada, all about Alberta and the norms here. And just also the added stress related to a lack of familiar support that's here. And they also discuss seasonal differences. So some of them are not used to our long winters, but also how short the days may be as well. We also wanted to share just a couple of things that participants did share in terms of what they are doing in their communities on the individual level to improve their well-being. So for example, one participant talked about the power in numbers, being able to bring those individuals with similar lived experiences together in order to raise awareness of their well-being, but also to make it more of a priority for city council, and also to connect. For example, the other second participant talked about connecting with small businesses in the community who maybe want to help them or sponsor them in some way in their initiatives. And the final example is actually a more pragmatic example, where one individual talked about setting up a one-stop shop. This was for women experiencing domestic violence, in order for women to be able to go and access any material needs that they might need. And kind of to close off, so the themes across the populations that we found, once again, is that the ability and opportunity to build and maintain relationships is very important. It not only impacts their relational well-being, but it also having that power in numbers in order to come together and to make a change in the community to improve their well-being. Also, taking an active role in planning and implementing supports is very important. It's important to not just listen to what their needs are and how their well-being is impacted, but also to let them have an active role in deciding what to do to improve their well-being. A lot of these individuals, they have many ideas of what can be improved and what can be done. And then also having the opportunity to contribute to their communities in some way, whether that is through advocacy or through volunteering. Just so to conclude, kind of the next steps. So we've done the focus groups with these communities, and we've shared these results with the collaboratives in those communities, and there's a lot of ideas that have been generated in terms of what to do next and what they want to prioritize, and what kind of initiatives, what kind of services do they want to, programs as well that they want to start in order to start improving some of these areas. But we've also developed, like we did in the previous, when we worked with people living with dementia and their carers and collaboratives, we also developed well-being sections for each of these populations. And those well-being sections essentially will help collaboratives go over these questions to understand what's positively impacting people's well-being in the community, what can be improved, where are the gaps, and also to understand what is a priority at the moment and what should be focused on. And the goal is eventually to develop just one well-being guide that can be applied to any community, to any population that they want to focus on. And yeah, that's the end of the presentation. Just this last slide here has our website where you can find more information about the well-being model, but also the well-being guide that I talked about and any of the other work that we are doing, as well as it has our contact information there as well. And that's all for that I have. Thank you so much for your attention.
Thanks for that, Alexandra. Thank you. Again, interesting thoughts around the distances people have to travel when we think about the distances we travel, and we do play that into lots of our discussions, so quite interesting. Any questions from anyone? No questions in the house. Any questions online? No. Okay. Thank you, Alexandra. Thank you for that. I think we're going to take a break now because we've got to wait for the other sessions to finish, haven't we? So we'll take a break and then we'll start again at 3. Thank you.
Gwasanaethau cymdeithasol Cyngor Gwynedd, ac a deud y gwir dylan sy'n tu ôl i gomisiynu yr adroddiad Llechen Lan. Dydy o ddim yn newydd da, da ni wedi gwneud y cyflwyniad yma o blaen, a mae yna bethau eitha dychrynllyd a pethau sy'n gwneud i rwy'n boeni am y dyfodol, ond mi wna i adael i dylan fynd trwy hynny efo chi. Fe gomisiynwyd yr adroddiad yma nôl yn mis Mehefin 2023 pan wnaethon ni ffurfio grŵp tasg a gorffan dan arweiniad Dylan i edrych ar lle da ni yn mynd o ran y gwasanaethau i'r dyfodol. Fe wnaethwyd gwaith ymchwil trwyadl yn lleol, yn rhanbarthol, yn genedlaethol am hyn, ac nod Llechen Lan yn wreiddiol oedd darganfod gwir gost darparu gofal gwasanaethau oedolion eleni mwyn gallu cynllunio i'r dyfodol 10 mlynedd, 20 mlynedd i'r dyfodol. Mae yna un paragraff dwi eisiau ddarllen allan i chi, dwi wedi sgwennu lawr, a hwn sydd yn gwneud ni sylweddoli beth sy'n blaenau ni. Mae'r adroddiad yn benodol ar gyfer Gwynedd, ond y gwir ydy mae o'n wir am bob awdurdod a bob rhan o Gymru i'r dyfodol. Nid yw sefyllfa darparu gofal cymdeithasol I bobl hŷn yng Ngwynedd yn hyfyw nac yn gynaladwy, ac os na newidiwn i'r ffordd o weithredu, ni fydd yn bosib darparu gofal cymdeithasol i'r dyfodol. Na pa mor ddychrynllyd ydy hynny a deud gwir ynde. Felly mi wna I sefyll I lawr, mae adael I dylan, mynd â chi trwy'r adroddiad yn fras. Mae o'n adroddiad eitha swmpus. Dwi wedi dod â copi fama I chi a mae'n bosib mynd I gael copiau I chi. Felly geith dylan fynd trwy'r adroddiad a wedyn mi ddau jyst I gloi wedyn cyn cwestiynau. Ac uchel chi gyd adra yn poeni lot am y dyfodol. Joch di hyn. Dylan, os oedd I ti.
It's a great guy, travel in England.
I think you said. We're in the rain.
Mae'n fwy fy hen a pharchus, ac arian yn fy nghod a phob beirniadaeth drosodd. A phawb yn canu'n nghod, mi brynai fwthyn unig heb ddim o flaen ei ddor, ond creigiau Aberdar, a thonau gwyllt y môr. Hynna'n oedd hwnna, bardd o Wynedd, bardd mawr o Wynedd, oedd yn deud pethau mawr am sut oedd o eisiau byw pan oedd o'n hen ddyn. Pan oedd o wedi tyfu'n hen, sut oedd o eisiau byw fatha rebal eto. Tonnau gwyllt y môr yn ei gynddeiriogi o, a fynta'n llawn hwyl yn cael byw fel oedd o eisiau byw am y tro gyntaf. Bywyd braf, bywyd da I bawb. Llun arall, oedd gen ni Lennon y McCartney, de. Will you still need me? Will you still feed me when I'm... Well, 64 oedd o, dwi'n meddwl, ond 64. Dydy 64 ddim yn hen iawn, nac di? O, mae rhaid ni gael fwy o mateb na hynna. Dydy 64 ddim yn hen iawn, nac di? Na, dydy o ddim. Reit, dydy o ddim yn hen iawn, dwi'n meddwl. Dim ragor, beth bynnag. A mae yna rhywbeth am sylweddoli, nôl yn y 60au, oedd 64 yn cael ei weld fel rhywbeth hen gen bobl ifanc. Oedd o'n sylweddol a mae yna newid mawr wedi bod. Mae yna shift mawr wedi bod yn cymdeithas ni, yn cymunedau ni. Tasau rhywun yn dod o'r gorffennol pell, mewn tardus Dr Who, ac yn cyrraedd yng Nghymru heddiw, be fysa'n dychryn nhw? A fysa gweld technoleg fel hyn yn ei dychryn nhw? A fysa gweld ffôn symudol yn ei dychryn nhw? Falle ddim, de, datblygiadau. Dwi'n meddwl na be fysa'n ei dychryn nhw ydy mynd am dro ar promenad Llandudno a gweld miloedd o bobl yn ei 80au a 90au yn byw bywyd iach ac yn mwynhau hunain yn fannu, yn edrych allan dros y môr, a'r heriau mae hunain yn roed I ni. I ni sy'n gweithio mewn gwasanaeth gymdeithasol, dwi eisiau dathlu'r ffaith bod ni'n gallu byw yn hun. Mae o'n gret, dydi? Tydi o'n wych bod ni'n gallu byw yn hun. Dwi'n gallu edrych ymlaen, gobeithio, at gael gweld wirion a wiresau. Mae fy rhieni fi dal yn fyw. Mae gen I am hlant I yn gallu gwario amser efo I nain a'i taid a'i mamgu a ci. A mae hynna'n wych, dydi? A mae nhw'n gallu cyfrannu'r gymdeithas. Mae o'n holl wych. Ac ar yr un pryd, mae o'n dod â'i heriau gyda fo. A dyna'r sgwrs gyda I chi. Da ni wedi wneud y darn o waith, fel oedd y cynghorydd Dilwyn Morgan yn ynghyflwyno I chi. Da ni wedi wneud darn o waith. Fi sy'n sefyll yn fan hyn heddiw, ond nid y fi nath y gwaith caled mewn gwirionedd. A dwi'n mynd I henwi nhw, oedd Emyr a Manon, oedd Gwyn ac Elin, mi oedd Alun ac Aled, Lois a Jessica sydd ddim yn gallu bod yma heddiw nath reoli'r prosiect. A maen nhw I gyd wedi gweithio ar hwn. mwyn datblygu y gwaith yma. Es i ddarllen yn rhywle rhyw dro de, fod babi sydd yn cael ei eni heddiw ar gyfartaledd yn mynd i fyw mis yn fwy na babi gath ei eni llynedd blwyddyn yn ôl. A mae hynna wedi bod yn wir bob un flwyddyn am dros 100 mlynedd. Meddylwch am y peth. Honna'n stadegyn i fi sy'n neud i fi feddwl eto, ac i ystyried pa mor wych ydy hynna. Ond wrth gwrs, fel y gwelwch chi, mae'r her yn go amlwg, achos yn y Gymru wledig, yng nghefn gwlad Cymru, mi yda ni yn gweld sefyllfa go wahanol. Dim ond fod pobl yn byw yn hŷn, fod pobl yn gallu byw yn eu cymunedau'n hirach ac yn brafiach, ond mae yna bethau eraill yn digwydd hefyd. Mae gennym ni fewnfudo sylweddol, mae gennym ni nifer fawr o bobl yn dod i ymddeol i fewn i Wynedd ac i y Gymru wledig. A be arall sy'n digwydd ydy fod gennym ni nifer fawr o bobl hefyd yn gadael Gwynedd. Mae gennym ni allfudo sylweddol yn mynd yn ei flaen. Brain drain, beth bynnag ydych chi'n alw. Mae gennym ni ddadboblogi cefn gwlad sylweddol, a mae honna'n her. A mae honna'n her hyd yn oed yn fwy i ni o fewn, wel, yng Ngwynedd. Dwi'n dychmygu, ond dwi ddim yn gwybod, ond dwi'n dychmygu bod hyn yn wir yng Ngheredigion, yn Sir Benfro, yng Nghyfyrddin, ag ati ag ati. Dwi'n go siŵr bod hyn hefyd yn wir fanna. Felly, fel y gwelwch chi, mae'r niferoedd yn newid ar sbîd. Be nath y tîm oedd yn neud y gwaith yma oedd edrych ar beth oedd wedi digwydd yng Ngwynedd dros y 10-20 mlynedd ddiwetha. Wedyn edrych ar be oedden nhw'n rhagweld oedd yn mynd i ddigwydd yng Ngwynedd yn defnyddio projections y Llywodraeth Cymru wedi darparu projections. Ac wedyn yn gallu deud, dyma da ni'n mynd i weld sy'n mynd i ddigwydd dros y 10 mlynedd nesaf, yr 20 mlynedd nesaf. Felly mi welwch chi bod y canran neu'r nifer o bobl sydd dros 65 yn mynd i gynyddu'n sylweddol. Dwi'n mynd i fynd i ddarllen hwnna allan i chi ag egluro fo bob tamed. Jessica sy'n fod yma, Jess, os ti'n gwylio hwn, ti sy'n fod i allu egluro hynna. Felly, dwi'n mynd i allu dweud hynny, ond dyna sut mae'n gweithio. A mae'r gwahaniaeth yn y niferoedd o bobl hŷn yn sylweddol eto. Fel y gwelwch chi'n fanna, da ni'n mynd fyny o tua 27,000 i tua 32,000. 12,000 ar hugain dros gyfnod o 20 mlynedd. Felly, da ni'n sôn am gynnydd sylweddol yn y niferoedd o bobl. A mae'r cynnydd mwyaf, fel y gwelwch chi'n y bobl hŷn, yn y bobl 85, 90 plus. A mi welwch chi hefyd fod yna chydig bach o newid tua'r diwedd, achos mae'r grŵp iengach 65-69 yn lleihau. Felly, dydy hon ddim yn stori o ofid am byth. Mae yna rhyw bwynt yn dod lle mae'n mynd i dipio a mae'n mynd i ddechrau troi nôl. Ond ddim am 20 mlynedd dda. Mae yna rhyw 10 mlynedd 20 i ffwrdd anffodus. Ond mae'n bwysig nodi hynny, achos mae rhai o'r cynlluniau sgennyn ni i drio mynd i'r afel efo hyn yn dweud bod ni'n mynd i adeiladu pethau. Bod ni'n mynd i greu pethau. Ond mae yna beryg mewn creu pethau os nad fyddwn ni angen nhw mewn 40 mlynedd. Felly mae yna rhywbeth o ran cynllunio. Mae gwasanaethau cymdeithasol yng Nghymru ac ym mhobman yn ymladd tanau bob dydd. Os ywch chi fewn i dîm gwasanaethau cymdeithasol henoed yn Gaernarfon, yn Nolgella, yn Penrhyn Deudraeth neu yn Mangor, mi wnewch chi weld tîm dan straen mawr yn gweithio'n galed iawn, yn ceisio cefnogi pobl hŷn, pobl hen iawn i ddod allan o'r ysbyty. A'r pwysau enfawr o'r ysbytau i ddweud, da chi'n mynd gweithio ddigon caled, da chi'n mynd cael pobl allan o'r ysbyty ddigon caled, a maen nhw jyst yn gweithio. A mae yna rhywbeth am pwy sy'n sefyll yn ôl ac yn edrych ar pwy sy'n cynllunio i'r dyfodol. Pwy sy'n deud, allwn ni ddim jyst cer ymlaen fel hyn, mae rhaid i ni stopio ac ystyried a meddwl sut da ni'n mynd i weithredu wrth symud ymlaen. A da ni'n dechrau cyrraedd y pethau sy'n ddychrynllyd braidd felly. Yn fan hyn, be da ni'n weld ydy y bydd y galw am ofal, gofal cartre, gofal preswyl, gofal nyrsio, yn cynyddu 57% mewn 20 mlynedd. 57% yng Ngwynedd mae hwnna. Fel dwi'n dweud, mae'n siŵr bod yn wir ar draws y siroedd eraill. Ond mae hwnna yn her o ddifri ni dydy. Yn her go iawn. Ond beth sy'n ddychrynllyd hefyd ydy yn y graff cyntaf yna, os welwch chi lle mae'r glas gole ar y brig y 2826 yna, rheina di'r oriau da ni wedi asesu amdanyn nhw heddiw a da ni ddim yn gallu darparu. Mae yna waiting lists. Right. Felly, nid problem o rhywbeth sy'n mynd i ddigwydd mewn 10 mlynedd, 20 mlynedd i hon, mae'n digwydd rwan. Da ni'n ei chanol i. Tybed faint o'r uwchreolwyr yn y cynghorau sir neu yn y byrdde iechyd neu yn y llywodraeth sydd yn gweld hyn mewn gwirionedd a sy'n cymryd y cam yna nôl ac yn dweud mae yna broblem mae di'n taro ni, mae rhaid ni stopio trio wneud mwy o'r un peth, mae rhaid ni stopio taflu mwy a mwy adnoddau ar ysbytai a dweud delayed transfer of care am byth. Mae rhaid ni stopio hynna, mae rhaid i ni feddwl am atebion eraill. Da ni wedi cyrraedd y pen draw yn barod, a mae yna waith i ddod. 57%, ond go sylweddol, dydy. A mae'r effaith ar hynny wrth gwrs, yn hyd yn oed yn fwy, ar y gweithlu sgennyn ni, ac hefyd ar yr arian sgennyn ni. So ni wrth y modd yn sefyll fan hyn yn dweud bod ni mewn cyfnod o arian mawr, bod yna ddigonedd ym mhob man, yn anffodus ni felly mae hi. A pan da ni'n siarad am dwf o 57% mewn galw am ofal, da ni'n siarad wrth gwrs am dwf o ddegau o filiynau o bunnau yn faint mae'n mynd i gostio i'r cyngor sir ac i'r trefthalwr. Arian sydd jyst ddim yna, ac i ddeud y gwir, da ni'n gweithio o fewn y cynghorau ar hyn o bryd, fatha bob bwrdd iechyd hefyd i drio lleihau faint da ni'n wario. Mae'r toriadau'n sylweddol, does gennym ni ddim o'r arian yna ar gael ar hyn o bryd. O ran yn gofalwyr ni, mi welwch chi'n fanna bod o'n mynd o 2003 i 2809. Da ni'n mynd i fod angen 800 yn fwy o ofalwyr mewn 20 mlynedd. Tydy hynna ddim cweit digon dychrynllyd, lwch. Achos, da chi'n gweld yr ei llwyd, da chi'n gweld y gofalwyr bach llwyd na sgen i ar y diwedd fanna ar 2023. Hynna di'r gofalwyr da ni ddim yn gallu recriwtio ar hyn o bryd. Hwna di'r waiting list. Hynna di'r gofalwyr na sydd gennym ni. Da ni'n mynd i fod angen dros 1000 yn fwy o ofalwyr mwyn gallu darparu. Yng Ngwynedd, rhwng 2011 a 2021, mi nath y nifer o bobl oedran gwaith rhwng 16 a 65 oed leihau o 5,000 o bobl. Mae yna'n 42 o bobl bob mis. 8 o bobl bob wythnos, reit? Mae Gwynedd wedi colli 8 o bobl bob wythnos am 10 o bobl oedran gwaith. Felly pan da ni'n deud bod ni'n mynd i fod angen mwy o ofalwyr, dyn nhw ddim yna. A da ni'n gwybod lle maen nhw'n mynd. Fel Cymro Cymraeg, dwi'n mynd am dro i Gaerdydd, a dwi'n mynd i Ely a Grangetown a Canton ac ati, a dwi'n mynd clywed acenion Caerdydd, be dwi'n clywed ydy acenion Gwynedd a Ceredigion a Sir Gyfyrddin, Ynys Môn. Da ni'n gwybod lle maen nhw'n mynd, a mae hynna'n gret. Mae canran siaradwyr Cymraeg, Grangetown, wedi mynd o 300 i 37%, mewn rhywbeth wedi 20 mlynedd. Nid addysg Gymraeg ydy hynna'n anffodus. Swn i wrth y modd yn dweud fel arall, ond nid dyna ydy o. Mae yna allfudo enfawr yn digwydd, ac mae hynna'n creu her sylweddol i ni. A dyma nhw'r un ffigurau eto, ond tro ma ynglyn â'r staffio, jyst yn ei ddarparu o mewn ffordd arall. Da i dorri lawr yn hyn. O ran faint o gweithlu da ni'n mynd i fod i angen ar gyfer gofal cartre, cartrefi henoed, cartrefi preswyl ag ati. Yr ochr dda i hyn, wrth gwrs, ydy bod ni'n gallu deud mai fel yna fydd hi os na da ni'n neud dim byd. Fel yna fydd hi os da ni jyst yn cario ymlaen i wneud yr un peth. Os da ni jyst yn cario ymlaen i wneud yr un peth a da ni wedi wneud dros yr 20 mlynedd ddwytha, fel yna fydd hi. Ond mae yna bethau da ni'n gallu wneud yn wahanol, does? Yn does? Oes, Dylan? Gret. Wel, mae yna. Dwi'n deud chi bod yna. Dwi'n siŵr bod yna, iawn. Felly, mae gennym ni rhestr yn fan'na o bethau dwi'n meddwl y gallwn i wneud yn wahanol. Maen nhw'n bethau da ni gyd yn wneud eisoes, mae'n siŵr, ond mae yna lawer mwy ohono fo i wneud. Da ni'n wneud hanner digon ohono fo. A mae hon yn sgwrs da ni'n cael efo'n tîmau gwaith cymdeithasol a therapyddion galwedigaethol bob dydd ac yn trio perswadio a trio sicrhau bod nhw o dan y pwysau enfawr yma o drio gael Mrs Jones allan o'r ysbyty yn deud, reit, mae rhaid ni trio meddwl yn wahanol. Mae rhaid ni drio neu rhywbeth yn wahanol yn hyn. Ac felly maen nhw'n cynnwys tai gofal ychwanegol, extra care. A mae'r llywodraeth wedi bod yn dda iawn i ddweud y gwir yn rhoi arian tuag at extra care yng Nghymru. A mae o'n beth sylweddol. Mae'n arian sylweddol sydd drwy'r RPBs. Mae yna Housing with Care Fund. Mae yna IRCF. Mae yna arian ar gael ar hyn o bryd i wneud hynna. Mae o'n rhywbeth i ni ddathlu. A mae yna gynlluniau gennym ni i ddatblygu mwy o extra care. Gwaith ar sail cryfder, sicrhau yn bod ni'n gweithio yn hytrach na gofyn i bobl, wyt ti'n gwybod beth sy'n bod yn ti? Nes i ddarllen wyddoch chi, sori Dilwyn, dwi'n mynd oddi ar tangent, ond mae Dilwyn yn nabod i felly dwi. Ond gethon ni ryw ddogfen gen y llywodraeth wrth ystwytha, dwi'n gwybod os rhywun arall di gweld i. 50-day challenge. Beth felly, man bach. Mae o'n mor nawddoglyd, condescending, ac mae o'n deud ar y drydydd tudalen, mae yna ryw was sifil, gobeithio bod chi ddim yma, mae yna ryw was sifil di sgwenio yn amlwg, ond mae o'n deud rhywbeth fel, every patient must be able to answer this question on the first day in hospital. A'r cwestiwn cyntaf ydy, what is wrong with me? Yeah? Dyna fo, gath o fynd erbyn. Dyna ni. Anyway, gwaith ar sail cryfder, gwaith ar sail cryfder. Da ni angen edrych yn wahanol a gweld be ydy asedau Mr and Mrs Jones. Be sy'n bwysig iddyn nhw. Sicrhau bod ni'n deall be sy'n bwysig iddyn nhw. Ac yn gweithio efo nhw i allu gwneud perthnasau. Nes i fwynhau gwylio be oedd y wraig o Canada yn siarad amdano fo gynnau, achos i rheini o'n chi oedd yn y gweithdy hwnnw. Achos oedd hi'n egluro mai be oedd nhw wedi ffeindio, y peth cyntaf un oedd yn bwysig oedd relationships. Rheini o chi oedd yma yn gwylio hwnna, relationships. Mae gwasanaethau gymdeithasol ar hyd blynyddoedd wedi rhoi lot o sylw i wneud pethau. Mynd i'r tŷ bach, bwyta, gwisgo ag ati. Pan ydych chi'n gofyn i bobl beth sy'n bwysig i chi, maen nhw'n deud gweld yn heulu, gweld yn ffrindiau, peidio bod yn unig. Mae bobl yn deud pethau fel dwi eisiau gweld un person bob dydd. Dyna'r math o beth sy'n bwysig i bobl. Bod ni'n sicrhau bod bobl ddim yn unig a bod nhw'n gallu bod yn rhan o'i cymuned. Wyddoch chi, a gyda maddiwch i mi gyfieithydd, a diolch i'r cyfieithydd am wedi gwaith, ond maddiwch i mi, dwi'n mynd i roi cerdd fach. Donald Evans na'n sgwennu gerdd yma, a mae'r gerdd yn mynd. Mae cwrw well na'i gilydd, ond nid oes cwrw gwael. Yn lle y mae fy ffrindiau, mae'r cwrw gorau i gael. Wyddoch chi, joc fach di de, diti fach, ond mae'n deud y cyfan dydy. Achos lle mae fy ffrindiau, mae'r cwrw gorau i gael. Neu, i fynd yn ôl at Lennon and McCartney, de. I'll get by with a little help from my friends, iawn. Dyna sy'n bwysig, de, bod pobl yn gallu ymwneud â'i teuluoedd, â'i ffrindiau, bod yn rhan o'r gymuned. Ac felly, mae'r gwaith ar sail cryfder yn holl bwysig a bod ni'n symud oddi ar y model meddygol yma sgennyn ni a bod ni'n symud tuag at gefnogi pobl yn y gymuned i fyw i bywyd yn dda. Teleofal, roboteg, eto ddoi nôl ato fo, ond mae o'n hanfodol. Mae'r pethau yma'n datblygu ar gyflymdra rhyfeddol, dydyn? A da ni angen mabwysiadu nhw a wneud yn sicr bod ni'n neud gorau ohonyn nhw, bod nhw'n galluogi ni i wneud yn gwaith. Gwaith yn y gymuned, i sicrhau bod y gymuned yn hygyrch, Un o'r prosiectau mwyaf da ni wedi gwneud yng Ngwynedd yn ddiweddar, ac o'n i'n darllen bod Ceredigion wedi gwneud rhywbeth tebyg yn fan'na, ydy Gwynedd Oed Gyfeillgar. A da ni wedi llwyddo i gael y World Health Organisation i roi achrediad i ni ar y peth. A mae Gwynedd erbyn yn oed gyfeillgar. Ond beth sy'n ddifyr am y peth ydy mae nid gwasanaethau cymdeithasol sy'n gallu ateb problemau gwasanaethau cymdeithasol. Waw, ynddo? Mwyn cael bobl i allu byw yn eu cymuned, mae rhaid ni gael meinciau ar yn strydoedd ni, mae rhaid ni gael goleuadau da, mae rhaid ni gael toiledau ar agor ac yn hygyrch ac yn amynediad hawdd iddyn nhw ar yn strydoedd ni. Mae yna bethau gallwn ni wneud mwyn galluogi bobl i fyw yn eu cymuned a peidio bod yn unig a bod yn rhan o'r gymuned. Mae o'n holl bwysig bod ni'n gwneud hynny. Ac yn ola'n fan'na, mae taliadau uniongyrchol, direct payments, a mae rheini o'ch chi, os da chi'n gweithio yn y maes, da chi'n gwybod amdanyn nhw, ond mae o'n yn galluogi ni i darparu gofal i rywun drwy ddefnyddio Mrs Jones lawr y stryd yn hytrach na defnyddio gofalwyr. Felly, os da ni'n brino ofalwyr, da ni'n gallu cadw'r gofalwyr at rheina dro fan'na, a mae Mrs Jones yn gallu gwneud y gofal i Mr Jones fan'na. Felly, yn sicr, mae yna bethau gallwn ni wneud. Does dim cwestiwn am y peth. Felly, yn y graff yma, sy'n chydig bach yn gymleth. Allen nid y fideo person gorau egluro'r pethau yma. Ond, mi welwch chi, mae'r linell, y dotted line ar hyd y gwylod, yr un ddu yna, ydy be da ni ar hyn o bryd yn gallu ddarparu. Dyna ni synwyr? Dyna faint o ofal da ni'n gallu ddarparu ar hyn o bryd. Os da ni'n cario ymlaen i asesu yr holl bobl sy'n dod drwy'n drysau ni ac yn deud dyma faint o ofal da chi angen dros yr 20 mlynedd nesaf, y linell oren na sy'n mynd fyny fel yna, honna ydy'r linell, dychrynllyd. Be nath y tîm oedd edrych ar sut mae siroedd eraill yn gweithio. Nath nhw edrych ar y siroedd sy'n darparu lleia o ofal. Nath nhw gymharu siroedd gwledig, 8 sir wledig arall Cymru, a dweud, mae'r sir yma yn darparu, dedwn ni bod ni'n darparu cyfartaledd o 10 awr yr wythnos o ofal i bob Mrs Jones. Right? Mae'r sir yma dim ond yn darparu 6. Reit, beth sy'n ni'n gallu efelychu hynny? Mae'r sir yma'n neud hyn, beth sy'n ni'n gallu efelychu hynny? Mae gen y sir yma hyn a hyn yn llai o bobl mewn cartrefi. Beth sy'n ni'n gallu efelychu hynny? Tasa ni'n darparu cyn lleied, a bob un sir arall sy'n darparu lleia, mi fysa ni'n cyrraedd y llinell felen. Rwle yn y canol ydy'r llinell las, sydd yn teimlo chydig bach fel rhyw gyfaddawd. Dwi'n dod â chi nôl at y pwynt, de. Be da ni'n gallu darparu ar hyn o bryd ydy'r llinell ddu, dotted line ar hyd y gwylod. Hyd yn oed, tasau Cyngor Gwynedd yn gallu darparu cyn lleied ar bob un o'r gwasanaethau yna cyn lleied ar sir sy'n darparu lleia yng Nghymru. Fysa ni dal ddim yn gallu gwneud dim byd am y peth, mae gennym ni fwlch, mae gennym ni broblem. A mae hwnna'n rhywbeth sy'n yn poeni ni, sy'n ymhryderu fi. Dwi'n betrus am i ddeud o mor onest â hyn wrthoch chi. Ond mae'n rhywbeth dwi'n meddwl bod rhaid i ni gydnabod a gweld mae gennym ni broblem. Be da ni'n mynd i allu wneud yn wahanol? Hyd yn oed tasen ni'n wneud pob peth, da ni dal yn gwylio bod gennym ni broblem. A mae'r graff yna yn cael ei ddangos jyst mewn ffordd chydig bach yn wahanol eto, drwy ddeud, tasen ni'n wneud cyn lleied, a phawb arall, cyn lleied ar ei sy'n darparu lleia, mi fysa y bwlch yn lleihau bydde, yn ariannol ac o ran pobl hefyd. Mae yna bwynt i wneud yn fan hyn wrth gwrs. Allwn ni ddim cymryd yn ganiataol bod y gwasanaeth sy'n darparu'r lleia yn darparu gwasanaeth da. Dyna fo. Mae jyst yn bwynt i wneud am hynny. Felly, da ni jyst yn gorfod byw efo hynny. Mi ydyn ni'n darparu rhai pethau wahanol hefyd o ran roboteg, nes i ddeud ni'n dod nôl eto. Mi ydyn ni erbyn hyn yn darparu gwasanaethau drwy roboteg. Mae'n siŵr bod chi gyd wedi gweld y cathod yma, lle mae rhywun yn gorfod i siarad efo nhw, rhoi mwythau efo nhw, rhoi bethau felly. A wedyn y gwely yma sydd yn wely robotic, fendlet di enw'r gwely, sydd yn helpu rhywun i droi hun yn y gwely hun, fel bod ni ddim angen rhoi gofalwyr i mewn. Felly mae yna bethau felly da ni'n neud yn barod, a mae'r stwff yna yn wych ac yn lleihau'r galw am ofalwyr. felly yn bethau i'w dathlu. Mae gen ni wefan Helpu'n Hun, mae Powys yma yn neud o hefyd Ask Sarah ar wefan Powys, a da ni'n neud o'n Ngwynedd Helpu'n Hun, ac yn debyg iawn, lle mae rhywun yn gallu rhoi wybodaeth i fewn i'r wefan, a mae o'n dod nôl ac yn dweud, pam na newch chi wneud hyn? Os da chi wir yn cael trafferth mynd i'r tŷ bach, pam na newch chi fynd i'r siop a prynu ABC? Neu oes na ryw bethau gwahanol a gallwch chi wneud, lly? A dyna di Helpu'n Hun. A mae Dewis Cymru wrth gwrs, mae'n siŵr bod pawb yn y stafell yn gwybod am Dewis Cymru, ond faint o'n ni sy'n ddefnyddio fo go iawn yn y ffordd iawn. A mae yna rhywbeth am sicrhau bod yn gwybodaeth ni am bob peth sy'n digwydd yn cymuned ni yn mynd ar Dewis Cymru. I rheini ni sy'n siarad Cymraeg, papurau bro, mi ddyle bod bob un dim sy'n digwydd sy'n cael ei ysbysebu mewn papur bro fod ar Dewis Cymru. Ond dwi'n mynd ei fod o'r hyn o bryd, ond mae gen ni brosiect sy'n trio symud i'r cyfeiriad yna fel bod pobl yn gwybod beth sy'n mlaen lle a bod ni'n neud nhw'n hygyrch. Gwyddoch chi y sleid yma, Jessica, fel sydd ddim yn gallu bod yma heddiw, sydd wedi paratoi y mwyafrif helaeth o'r sleidiau yma. Tan hwn, fi nath hwn. A da chi'n gallu gweld y gwahaniaeth, mae'n siŵr. Ond cwbl ydy hwn, ydy rhyw fath o, yn symboleiddio, os hoffech chi, yr her dwi'n newydd siarad amdani. Felly, mae gennym ni'n llai a llai o bobl oedran gwaith sy'n mynd i fod ar gael i ddarparu gofal. Eisoes yn digwydd, mae o'n mynd yn fwy heriol gydag amser, a mae o'n mynd i gario ymlaen i mynd yn fwy heriol. Poblogaeth hŷn ydy'r saith goch dramatig mellten yn mynd ar ei fyny. A wedyn, da ni'n trio edrych ar, wel, be allwn ni wneud i wneud gwahaniaeth. A dwi wedi rhestru rhai o'r pethau ar y brig yn fanna, a wedyn mae yna cwestiwn mawr. Pan o'n i'n fach, o'n i'n hoffi gwylio ffilmiau cowboys ar rhywbeth felly. Ac ar y pwynt yma, tasa hon yn ffilm cowboy, mi fasa yna reinforcements yn dod wan. Sa'r cavalry yn dod dros y bryn. Nes da chi'n hoffi Lord of the Rings, Helm's Deep, mae Gandalf yn dod. A'r milwyr i gyd yn dod o iachub y dydd. Swn i wrth y modd yn gallu deud hynna. Honna di'r cwestiwn. Does gen ni ddim cavalry, doedd na ddim cavalry. Mae rhaid i ni weithredu'n wahanol. Ac am hwnni, a hon ydy'r neges fawr, da ni angen cael sgwrs onest. Da ni angen i'r Llywodraeth gael sgwrs onest. Nid pwynt gwleidyddol, dwi'n neud rwan na i adael hynny, Dilwyn wedyn. Ond mae angen i'r gweision sifil, mae angen i ni fel cyfarwyddwr gwasanaeth cymdeithasol, mae angen i bawb sy'n gweithio yn y maes gael y sgwrs onest yma, achos da ni eisoes yn cael trafferth darparu, a da ni ddim yn mynd i allu darparu ar dyfodol ar y rad yma. Dwi'n mynd i drosglwyddo nôl i Dilwyn. Sydyn iawn. Diolch.
The chair just said get on with it, we really thought it was 3:30. Diolch Dylan. Os ydych chi ddim yn bobl adroddiad, mae Dylan hefyd yn llenor. Ac mae o wedi sgwennu erthygl, a mi wna i ddeud yn ei wyneb o fel dwi ddeud yn ei gefn o, arbennig iawn yn y Welsh Agenda, lle mae o'n gallu cynhoi yr adroddiad yma trwy sôn am Dr Who a Gandalf a The Cavalry. Felly dwi'n argymell bod chi wirioneddol yn chwilio amdan yr erthygl. Dwi'n meddwl na hwyl care ydy henw hi, a mae gael yn y Welsh Agenda. Mae rili yn bwerus yn cael y neges drosodd. A dwi am orffan fel dwi jyst eisiau dweud, oedd Dylan yn dweud pa mor bwysig ydy siarad efo'n gilydd. We're all in this together, dwi'n meddwl ydy'r neges yn Saesneg. Mr Chair, that's why I'm going to just finish off in English to say that events like this are so important to get us all together to discuss these issues, because alone we will not survive. So I think, the more we get together, discuss it with Welsh Government, without Welsh Government, we must stick together, otherwise we won't survive the next 20 years. Felly, diolch yn fawr iawn i chi gyd am y gwrandawiad. Diolch.
Diolch yn galon, I think is the phrase. So in terms of questions, I am going to step on somebody's toes and open up to a few questions if people want questions, because I think, you know, that is a stock presentation, and it is something that, you know, we go home with a real message there, and that is, you know, relevant to the whole of our patch. That's not a Gwynedd thing. That is a situation that we're finding ourselves in all the way through our patch, our Mid Wales patch. Any questions from anyone that we can take? Any questions? There's a couple at the back there, or one at the back there that's indicating for somebody else, but no. Copy. Where do we get a copy of the report? And even more importantly, where do we get a signed copy of the poem? Anyway. Yeah, so if you want a copy of the report, and we will take those requests through the Rural Healthcare Wales office so that we can channel those. We will not be printing them off, just so everybody knows. So yeah, that's where we'll get a copy of those. If you email our Rural Healthcare Wales office, we will sort that out for you. There's another question at the back there.
They won't need the same kind of care that my grandma relies on, because they think that technology is going to save them. They're able to order their groceries online, they connect with their grandchildren, some FaceTime, etc. And I think that to that extent, probably right, they will be able to make use of technologies that my grandma certainly isn't. But what can you tell us about the kind of changing needs, not just in terms of the numbers of
I'm advised I need to repeat the question. So I guess you asked me what the makeup of the population that are in need, and what the changing demographic or the changing needs are, I guess, and expectations. And I guess the answer to your question is in your question, isn't it? That there is a change in demand and people do expect things differently. So I don't know, I guess a show of hands here. How many people here as a lifestyle choice would want to go into a care home tomorrow? I guess let's ask another question. How many people here as a lifestyle choice would go to a hotel in London tomorrow if it was not en suite? Shared toilet. Would we do that? That's our care homes. Yeah, that's what we expect. So yeah, people's expectations are changing. My expectations, our expectations are changing. There's no doubt about that. And however, we're not seeing that yet in the demand. And we are seeing that people, when they get to that stage within their own frailty, that they are coming to us. And I guess that's because the choices are limited in reality. When you live in rural Wales, you know, there is a balance of what you can expect, and in reality, it's not available often. And it's our role to ensure that people are enabled to live the best life possible without making use of that care. At the moment, yeah, that's not happening. I think too, there's something about when you talk about the growth, there's also a cultural change happening when we have a large number of people moving into the area. So we do have, when we talk about communities and community participation, you know, that you do have areas where you have different events happening for different groups within the community. Often there's a group of people who've moved in, and then there's a group of people who are your local kind of residents who've been there all their lives. And that also creates a challenge when you're working in rural Wales, where you don't really have the mass, you don't have the population to sustain that. So we have a wider economic challenge, I think, and not just economic, but yeah, demographic challenge, I guess. I shouldn't have asked you a question when you spoke earlier, because I knew if I would have done so, you would have asked me a question back. There we go. Anyway, definitely.
Thank you, Dylan. Any other questions from anyone? Julia?
Diolch. I wanted to ask, at a time when there's, I'm going to use the word unprecedented system pressure across health and social care, which is what Dylan, you described in your presentation, that was so powerful. So thank you for sharing it. And at a time when health boards and county councils are under increasing financial pressures and are having to make temporary or long-term service changes. And we've got a workforce that's extremely stretched, as we indicated again in the presentation. How we as public sector organisations with our partners are actually going to lift ourselves out to gain the headspace to address this future challenge.
Dylan, you've got the answer to that.
Well, I think I do. I think I do have the answer to that, because we're here, aren't we?
Yeah.
This is where it needs to happen, and this is only the starting place, really, isn't it? So this conversation, I mean, the purpose of, Dylan Morgan asked that I put this forward, this presentation forward for delivering it today, because Dilwyn, as a politician and the cabinet, are keen for this to be raised as a political matter. Now, that's not for me to do. My role is to raise the issue into awareness, and then to say to the politicians, what are you going to do about it, really? So what is the next question, isn't it? But having that conversation in this kind of place, such a wonderful opportunity that we have this kind of conference to talk about these issues and to raise them to the attention of our political masters, I guess. So ideally, this conversation then goes further up the chain. And Dilwyn talked about the article in Welsh Agenda. I think Welsh Agenda is coming out in this week, in fact, so it'll be out this week, right? But and there's another version of it coming out in Barn, which is the Welsh language publication. But there's I think social services, and my colleagues from ADSS, the Association of Directors of Social Services, wouldn't be happy with me saying this, I'm sure. But I think there's something about health have a monopoly on peer-reviewed journals and evidence-based practice, and on ensuring that their clinical knowledge and their working upon that and creating guidance and rules accordingly, all of that is in place and has been for decades, if not centuries almost now. So, everyone, the man on the street would know about the BMJ and Lancet, wouldn't they? And all of those other journals that are out there. Any social care journals out there? There's an issue here. I think there's an issue that it's not being discussed, it's not being raised as an issue. And there's a conversation being held, which is all about hospitals. Not even about the NHS. It's not even about district nursing or therapists or psychologists. It's all about hospitals, and as if that's the block. It's almost a Welsh thing that we need to talk about hospitals. So I think there's I have a view, and I'm not here to talk about it, but very briefly, that the only way we can release the capacity in the hospitals is by stop talking about it and start convincing ourselves that the way forward is to prioritise well-being of people in the community, enable people to live their best lives in the community. Do that right, that will release the hospital. That will, I know it will, it's a fact, it will do it. But we're not given the opportunity to do that. So coming back to your question, the opportunity here, the reason why I'm publishing this in the Welsh Agenda is because of that lack of public discussion, that lack of evidence-based peer-reviewed journals, etc. We as directors of social services and others in this kind of field need to start publishing, and need to start publishing opinion even, and saying, we need to have a conversation about this, and these are some suggestions. So yeah, I guess that's the answer to your question.
Yeah, I absolutely support that, and I think there's some tiny green shoots of thinking that are starting to look at things in the community, like enhanced community care numbers and things of that nature. But when we look at what we're being examined on as a health service, it's all about acute hospitals, pathways of care delay, all about acute hospitals. So there's a real need to change the focus in what we're looking at and what we're measuring to be able to do that. A lot of the things we can't measure because we haven't got the digital systems to be able to measure the things out in the community. So there is some need to move that thinking. Any more questions from anyone? Anything online? No. Okay, so that brings me then to the close for today. Good night. And that's only day one. There's another 2 days to go yet, folks, in terms of those that are coming back. What are the take homes? Status quo is not an option. We can't stay as we are. There is no way that we can stay as we are. Care closer to or at home is great, providing you can provide it and providing you have a method of providing it, keeping people at home. The more people a health service keep at home, the more stress it puts on social care and others within the community to be able to deliver that. We've got evidence today, haven't we, of non-silo working, partnership working. Don't think in the silo in which your pay packet comes through, because it's not only associated with who pays you, it's about who needs you and what they need. Workforce played in a lot today. Workforce has played in on the conversation, the last conversation we've had. Grow your area is great if you've got somebody to grow. We've got to encourage our population, encourage our younger people to stay here, stay with us, give them opportunity, give them things that will keep them and grow them within our area. And with our population, with our people, we've got a big conversation to have, haven't we, across our populations around, what matters to them, what's their need, what do they want from us in terms of the need, not what we want to give them, what the prescription we write that they take the tablet and it all goes according to plan, because it won't. It's a conversation across society, cultural conversation, and around how we put more into our society. And the big thing is, I don't think anything's off the table. We've got to keep everything on the table and not sweep anything under the carpet if we're going to get somewhere going forward. Thank you for being here today. Those that are coming tomorrow, I look forward to seeing you tomorrow. Another day of exciting conversation. And as I say, there's plenty of time now for networking and for scoring posters. Plenty of stuff in the posters that is really worth taking home as well. Thank you all. Safe journey home, and thanks a lot.